Good evening, all. I'm Dr. Madan Kamble.
Hello, everybody.
Oh,
Hello, madam.
welcome.
We were waiting for you. Welcome.
Sunita ma'am has joined.
Welcome, madam. Sunita, madam, welcome.
Welcome,
Thank you,
ma'am.
dear. Thank you. Thank you.
So now we can start. Yes.
Okay.
Saiti, you can mute rest of them, and Madan, you can start.
Yeah. Good evening, all. On behalf of AMOGS Emergency Obstetrics Committee and along with OBGYN societies of Pandharpur, Akluj, and Osmanabad, we are having today's webinar on emergency obstetrics. And on behalf of this committee, I welcome all the AMOGS office bearers and Dr. Kiran Kurtukoti sir, who is President AMOGS, Dr. Bipin Pandit sir, immediate past President Dr. Pardeshi sir, Treasurer Madam Mahindale Madam, and our own Chairperson of the committee, Dr. Sneha Bhuyar ma'am. I also welcome Dr. Sunita Tandurwalkar ma'am, who is the chief guest of today's session, and guest of honor Dr. Kurtukoti sir, Pardeshi sir, and Ajay Mane sir. I also welcome all the speakers and chairpersons of all the sessions and all the panelists for today's webinar. I welcome Dr. Sneha Bhuyar ma'am, who is the main behind this program. I welcome ma'am for your welcome address. Over to you, ma'am.
Yes, thank you so much. No need to screen share, Saiti. Thank you so much, Dr. Madan, for just inviting me for the welcome address. I will not take much time. Just officially, I welcome all of you. A very good evening to each and every one of you. Respected AMOGS President Dr. Kiran Kurtukoti. I think Kiran is yet to join. Our Secretary of AMOGS, Dr. Bipin Pandit. Chief guest for today's program, Madam Sunita Tandurwadkar, and guest of honor, Dr. Rajendra Singh Pardeshi sir, Dr. Kiran Kurtukoti, and Dr. Ajay Mane. Of course, the rest of the AMOGS office bearers and the entire team of AMOGS. I welcome the President Secretaries of Akluj, Dr. Vinod Chetty, and Secretary Dr. Ganesh Wagmode, Osmanabad team, Madam Swami, and Secretary Dr. Parveen Palla, Pandharpur President Dr. Sudesh Doshi, and Dr. Sachin Pawar, Secretary. I welcome all the chairpersons, including Dr. Adinath Rajguru, who is the past President of Osmanabad Society. And I also welcome Dr. Kavita Kamble, Dr. Bharat Pawar, Dr. Sunil Sarde, Dr. Anuradha Garat, Dr. Sujata Gundewar, Dr. Vasudha Varke, and all my dear friends, Dr. Monica and Madan Kamble. All of you know that hypertension, hemorrhage, and sepsis, these are the three main killers of our women. Of course, anemia being the direct as well as indirect cause of maternal mortality. And so we are trying to club all these causes on priority. And so we have Professor Dr. Girija Wagh speaking on the management of eclampsia, Dr. Sushila Rani from Bangalore speaking on hypoglycemia and pregnancy, and myself, Dr. Sneha Bhuyar, will be moderating the panel discussion on the postpartum hemorrhage. So with this brief overview, I'll just welcome all of you, and I hand over to Madan once again for the invocation video. So can we have the invocation video, please? Yes, I think. So with this God's blessing, now we take the seniors' blessings, and it's my pride and privilege to introduce Madam Sunita Tandurwadkar, who is the President-elect of FOXY, and she's the Head of Department of OBGYN and Chief of IVF and Endoscopy Center, Ruby Hall Clinic, Pune. She's the advisor and consultant of DY Patil IVF and Endoscopy Center, past president of IAG, and of course, the new society, what she has also come up with the stem cell society as well. Madam is very innovative, and of course, she is here to guide us. So without much ado, I would hand over to Madam for her precious words. Over to you, Madam Sunita
Good
Tandon.
evening. Good evening, everybody. I'm so glad to see you all. As I always say, coming to AMOGS, any webinar is like coming home. Dr. Rajendra Singh Pardesi, sir, Ajay Mane, the way you have taken AMOGS ahead, which Nandita has taken, I think, one step. And the both of you have done such an amazing job. Especially the committee chairperson, the freedom what you gave, Dr. Pardeshi, sir. I think that's the reason why AMOGS has become so vibrant among all the states. And Dr. Kiran Kurtakoti, now I'm sure he always come out with the brilliant ideas, and with such a fantastic group of chairperson with him, he will do the great job. Sneha, whatever work anyone gives you, it is not only to the perfection, but you take to the different level altogether. Today's topic also combining Osmanabad, Akluj, and Pandharpur societies, but talking on all the important subject of obstetrics shows that you want to reach out to these B and C societies, all with thinking that it will add on the value to their practice, the way they were. Whatever amount of webinars are happening, whenever I attend those webinars, I feel there is something always, one carry on point you always will get. And today's your speakers, Girija, yourself, I think it will be one of the fantastic webinar anyone can have. Madan, lovely to see the amount of work you want to do. And same is with Monica. I think they want to come to the national, from the society to the state to the national. And I'm very sure we all will be more than happy to have them, and will work hard for all of you. AMOGS is आपलं घर आहे आणि घरच्या माणसांसाठी काम करायचं असतं. I wish you all the best, Sneha, for all your endeavor in, and you are a shining star of our Foxy.
Thank you, Madam.
Thank you. Thank you.
Thank you so much, Madam, for your blessings and your precious words. May I now invite our sir, our mentor, Dr. Rajendra Singh Pardesi, who has actually handled us towards the path of Foxy. And so, everybody knows sir, no need for introduction, but I will just say that sir was the chairperson of Food and Drug Committee Foxy, and he was a past vice president of Foxy, though all of you still continue to feel that he's the president of AMOGS. Over to you, sir, for your precious words. Hello, sir. Hello, sir.
सर तुमचा आवाज येत नाही. परदेशी सर तुमचा आवाज येत नाहीये.
Sir, please unmute करता.
Hello.
हा,
Am I audible?
Yes,
sir. Now it's
yes, sir.
Good evening, everybody. Respected chief guest and our Iron Lady, Dr. Sunita Tandolkar, guest of honor, Dr. Kiran Kurtakoti, Dr. Ajay Mane, and Dr. Girija Wag, Dr. Madhuri Mendre, Dr. Sudesh Doshi, and friends. First, I wish to congratulate Dr. Sneha Bhuyar, our ever active and ever smiling AMOG chairperson of Emergency Obstetric Committee, for organizing this webinar with Osmanabad, Akluj, and Pandharpur Society on the important topics like eclampsia management, hyperglycemia, and postpartum hemorrhage. This cause contributes about 35 to 40% of maternal mortality in India. And we are proud of our AMOGS members for their untiring effort to bring down our Maharashtra's maternal mortality at 33 per 1 lakh deliveries and our AMOGS aim is to bring down this MMR to a single digit. And with eminent faculties like Dr. Girija Wagh, Dr. Adinath Rajguru, Dr. Sushila Rani, Dr. Sneha Boyar, and chairperson panelists Dr. Lalita, Dr. Sudesh, Bharat Pawar, Dr. Kavita, Dr. Sushil Sarade, Dr. Vasudha, Dr. Sujata, Dr. Anuradha Garar, Dr. Monica Umbardhan, Dr. Madan Kamble. I think this webinar will really help in reducing MMR. I again congratulate Dr. Madan, Dr. Sneha Boyar, and Dr. Monica Umbardhan for this webinar. And especially, I wish every success to Dr. Sneha Boyar for her future endeavor in FOXI in forthcoming elections as Vice President FOXI. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much for your blessings and best wishes always, sir. So I think Dr. Kiran Kurtakoti, our president of AMOGS, is busy right now in some emergency, but he may join in some time. So we take this opportunity to invite Dr. Ajay Mane, our own vice president of FOXI. And of course, all of you know him, a very active, dynamic person, the past chairperson of the website committee of AMOGS as well. So without much ado, I think we listen to Dr. Ajay Mane and his precious words. Over to you, Dr. Ajay.
Yeah, thank you, Sneha Tai. Being a elder sister, you always order me to come, and I obey your orders. And I'll be doing my job of younger brother in this election. आणि माझी सगळ्यांना हात जोडून विनंती आहे की आपल्या ह्या बहिणीला आपल्याला फॉक्सी मध्ये व्हाईस प्रेसिडेंट म्हणून यावर्षी पाठवायचंच आहे. तुम्ही सगळ्यांनी मागच्या वर्षी पण मदत केलेली आहे, पण यावर्षी आवर्जून मदत करा. प्रत्येकाने किमान सुनीता मॅडमने सांगितल्याप्रमाणे त्यांना आपल्याला फॉक्सीमध्ये व्हाईस प्रेसिडेंट म्हणून पाठवायचं आहे. त्यामुळे प्रत्येकाने किमान 100 लोकांना आपल्याला आठवण करून सगळ्यांना वोटिंग करून घेणे हे आपलं क्रमप्राप्त आहे. ठीक आहे. चलो, respected Sunita madam, sir has given her a very beautiful nomenclature, Iron Lady of Maharashtra. She is such a dynamic personality. She is really Iron Lady. But I made one modification. She is a Golden Lady, not Iron Lady. त्यांच्याकडे एवढं सोनं असते ना की आपल्याला 1 वर्ष फॉक्सी चालेल असं मला वाटतं होते. त्यांच्या अंगावर तेवढं असते सोनं. तर रिस्पेक्टेड आवर मेंटर्स, राजन सिंग परदेशी सर, dear friend Kiran, and the coordinators Madan Bhai and Monica ji. Today's topics are very nice and the speakers are excellent. Basically, Dr. Girija Wagh is an excellent academician. ती तुम्हाला पूर्ण समजून सांगितल्याशिवाय सोडणारच नाही. त्यामुळे तुम्ही पूर्ण शिकणारच आज. आणि त्यांचा टॉपिक आहे मॅनेजमेंट ऑफ इक्लाम्शिया. आणि शी इज अ व्हेरी ग्रेट. आणि चेअरपर्सन आपला आदिनाथ भाऊ आणि गणेश दादा एकदम छान. Second topic is hyperglycemia in pregnancy, type 1, type 2 diabetes, gestational diabetes माहिती आहे. Fourth type मला माहित झालं परवा, that is psychological diabetes. उगाच लोकांना भीती असते, मला डायबिटीस झाला, मला डायबिटीस झाला, मला डायबिटीस झाला. तर हे सगळे छानपैकी समजून सांगतील आपल्या डॉक्टर सुशीला राणी, and the chairpersons are Dr. Lalita and our friend Dr. Sudesh Bhai from Pandharpur. आम्ही विठ्ठलाच्या दर्शनाला जात नाही, पण सुदेश बाबाच्या दर्शनाला जात असतो रेग्युलर पंढरपूर. आणि आपली ग्रेट मॉडरेटर मोठी बहीण आपली पोस्टपार्टम हिमरेज PPH ला स्नेहाताई, ज्याला आपल्याला मदत करायची आहे. आणि पॅनलिस्ट आहेत डॉक्टर भारत, डॉक्टर कविता, डॉक्टर सुशील, डॉक्टर अनुराधा मॅडम आमच्या उस्मानाबादच्या, माझ्या गावाच्या, डॉक्टर सुजाता अँड डॉक्टर वसुधा अगेन उस्मानाबाद धाराशिव त्यांच्या. एवढे सगळे छान टॉपिक, एवढे छान स्पीकर्स आणि एवढे सगळे असल्यानंतर आपण शिकणार म्हणजे शिकणारच 100%. ओके. त्यामुळं स्नेहाताई, तुम्ही खूप छान कार्यक्रम अरेंज केलेला आहे, त्याबद्दल आपल्याला धन्यवाद. तुम्हाला आमच्याकडून शुभेच्छा. आम्ही सगळेजण मिळून तुमच्यासाठी मन लावून काम करणार. पूर्ण महाराष्ट्र तुमच्या पाठीशी उभा आहेच आणि तो खंबीरपणे उभा राहील याची गॅरंटी. आजच्या कार्यक्रमात मला बोलवलं त्याबद्दल धन्यवाद आणि शुभेच्छा.
धन्यवाद अजय. खूप महत्वाचं आणि अतिशय चांगलं मार्गदर्शन आपण केलेलं आहे. आणि आता मी डॉक्टर मोनिका आणि डॉक्टर मदन यांच्यावर सुपूर्द करत आहे. परत एकदा मी सर्वांचे धन्यवाद मानते. आमच्या आजच्या प्रमुख अतिथी डॉक्टर सुनीता तांदुळवाडकर आणि अर्थात आमचे अतिथी गण डॉक्टर राजेंद्र सिंग परदेसी, डॉक्टर किरण कुर्तकोटी, डॉक्टर अजय माने, आपण सर्व प्रथितयश डॉक्टर्स आणि सर्व फॅकल्टी सर्वांचे मी आभार मानते मनापासून. आणि परत एकदा मी आपल्या सर्वांना विनंती करते की मी आपली उपाध्यक्ष फॉक्सी अखिल भारतीय संघटनेची उमेदवार म्हणून आपल्या सर्वांना विनंती करते की मला तुम्ही आपलं अतिशय महत्वाचं असं मत द्या. धन्यवाद.
Yes, thank you once again for all the guests and their blessings. Now we are moving to the academics. To start with the session 1, we have got the eminent speaker for the topic management of eclampsia, none other than Dr. Girija Wagh ma'am. May I have CV of ma'am, please? Oh, okay. We have got two chairpersons, esteemed chairpersons, Dr. Adinath Rajguru sir from Osmanabad. He was the past president of IMA Dharashiv and past president of Osmanabad OBGYN Society. He is IVF consultant at Rajguru's IVF Center and Akshay Hospital, Osmanabad. I welcome you, sir. And second chairperson is Dr. Ganesh Wagmode. He is currently the secretary of Akluj OBGYN Society and having private practice at Malshiras. I welcome. I request Rajguru sir to introduce our speaker, Dr. Girija Wagh. If Rajguru sir is not there, Dr. Ganesh can introduce.
Yes, Dr. Ganesh.
Dr. Ganesh.
Good evening, everybody. Myself, Dr. Ganesh Wagmode, Secretary of Akluj OBGYN Society, would like to introduce Dr. Girija Wagh Madam. Madam is Professor and HOD Department of OBGYN, Bharati Vidyapeeth Medical College Hospital, Pune. She is a senior consultant, Cloud9 and Apollo Hospital, Pune. She is a faculty professor. She is internal expert coordinator, medical resources.
डॉक्टर गणेश राहू दे कारण आता 7:30 वाजलेत. आय थिंक वी हॅव टू कम्प्लीट द एंटायर स्टफ ना. थँक्यू सो मच फॉर इंट्रोड्युसिंग मी. कॅन आय हॅव द स्क्रीन शेअर? सो paying my respects to the chairpersons, Dr. Rajguru, I can't see, but Dr. Ganesh, thank you for chairing this session. And thank you, Sneha and Monica, for trusting me with this topic. I hope I'm able to deliver to the expectations of the audience. And eclampsia is something which can be completely preventable and eradicable. And that is what we have been trying to do for the past nearly a decade through the National Eclampsia Registry. And we have been able to reach there to an extent, I feel. But, and with improved maternity care and all these things, we are definitely there. So I'll try to make it as simple as possible. The topic that I have been allotted today is eclampsia, and I have taken some excerpt from the ICOG certificate course because I felt that that was the most updated. I just delivered it 2-3 days back, and that was a lecture which was much appreciated by everybody. So let's come to the point. Let's understand what is eclampsia. We all know that it is new onset generalized tonic-clonic seizures or coma in a patient with preeclampsia, HELLP syndrome, and gestational hypertension. And it has a very high morbidity and mortality, definitely. And if you look at our country, the incidence is nearly about, preeclampsia itself is about 10% against the global incidence of about, say, 3 to 6%. And 2% of these women are at risk of developing eclampsia. And so therefore, if we look at 26 million deliveries per year in our country, we will find that we have to deal with nearly 5 lakh eclampsia patients per year. And therefore, this is something that requires attention. And I want to congratulate Sneha for bringing this very important topic into this foray. Now, despite advances in detection and management, preeclampsia, eclampsia remains a common cause of maternal morbidity and death, especially in resource-limited regions. And therefore, it's very important that we act before anything happens. And that is the reason why we have to be careful. Now, for understanding how to manage this condition, we must understand why do seizures occur. Now, popularly, it was believed that it is because of cerebral vasospasm and cerebral edema. But now the current understanding is that it is because of the uteroplacental ischemia, which causes release of certain molecules such as neurokinin, inflammatory cytokines, endothelins, and tissue plasminogen activators. And these go and stimulate the excitatory neuronal receptors and alter neuronal excitability, synaptic transmission, and neuronal survival independent of any vascular effects. And that has been identified. So, you know, the brewing of the ground is probably done from the first trimester itself. It's only important, remarkably important, that if we control hypertensive disorders of pregnancy diligently throughout pregnancy, we will definitely be able to prevent eclampsia completely. Being a little liberal with using prophylactic medications like magnesium sulfate, because I can see world over, and especially in Maharashtra, many times when I go into deep diving of patients who come to us as a tertiary care center, many times there's a lot of reluctance in giving this very important and valuable medicine. And that will help us, and I'm going to tell you how it would help. So when eclampsia occurs, there is definitely, why it occurs is there are certain changes in the neurosteroids. There is inflammation and infection which is responsible. And there is alteration in the barrier disruption, which causes breakthrough of the auto-regulatory mechanisms. And therefore, the woman would go into eclampsia. We all have learned that the theory now, which is prevalent from quite some time, is that we all know that the blood flow which is going to the placental site is always full of perfusion with dilated spiral arterioles, giving wonderful non-resistance blood supply to the placental bed when the implantation starts very early in pregnancy. And this particular migration or trophoblastic invasion continues till the pregnancy becomes 16 weeks. So our window of opportunity is in those 4 months. And that time, unfortunately, in patients of preeclampsia, instead of such wonderful trophoblastic invasion, there is partial trophoblastic invasion. And this can get detected at the first trimester itself, at the end of it, when we do the uterine artery pulsatility index. And this is the reason why the placental bed will become hypoxic. And this hypoxia in the placental bed will give rise to various release of cytokines. And that can give rise to hypertension, endothelial dysfunction, kidney, liver, and brain would get affected. And brain especially in the form of seizures. So therefore, we are having a huge window of opportunity where we can be alert, looking at the patient who is at risk, trying to deal with them, trying to investigate them diligently and prophylactically try to help them so that they don't get into this entire sort of an cascade and algorithm where eventually the raised blood pressure would cause her vasospasm in the cerebral vasculature, cerebral edema, and then eclampsia-like seizures. So if you look at eclampsia, it is a complication of pregnancy-related hypertension. And there are so many other things also which we require to differentiate it from. There can be infarcts, there can be press, and many times patients would come to you with blinding or, you know, some sort of a visual symptoms which we should be very sensitive to. And why it is important? Because it has short-term as well as long-term consequences. There can be intracerebral hemorrhage, there can be cerebral edema, press, increased blood-brain barrier permeability, cerebral venous sinus thrombosis, and cervical artery dissection, which can be quite life-threatening and killing. While over a long period of time, these women may develop vascular dementia, cerebral small vessel disease, ischemic and hemorrhagic stroke, white matter hyperintensity, and so many other things. So we have to be carefully protecting women against this condition. Now, I have been talking about press and what is this press, and we must congratulate our teams from, Indian teams from JIPMER, the anesthesiologist who observed this particular condition. And what did they say? That they found on MRI press, and this was typically seen in the hypodensities that were typically seen in the posterior margins, parieto-occipital lobes. And this is a characteristic feature of the press encephalopathy syndrome. And it is postulated that the vasogenic cerebral edema and ischemia of brain tissue is the reason. And it happens typically in the posterior circulation because that's more susceptible, because it has less sympathetic innervation of the vertebrobasilar vasculature to protect the parenchyma from rapid increases in arterial blood pressure. And the management is to discontinue if any insulting medicine is going on, control the woman's blood pressure, and treat the seizures. So when we look at who are at risk of eclampsia, as women with preeclampsia, gestational hypertension as well, Black and Hispanic race, advanced maternal age, nulliparous women, women less than 80 years of age, 20 years of age, sorry, multipetal gestation, preterm delivery less than 32 weeks, and lack of prenatal care. And whatever patients I have encountered in our tertiary center, my own antenatal patients do not have any such problems. Women are referred from outside, and they are the ones who have received very, very compromised or maybe say deficient antenatal care. And that is one very single thing that we can improvise to manage and prevent eclampsia. So the visual disturbances are something that one has to be very sensitive to. Blurry vision, diplomia, scotoma, photopsia, transient cortical blindness. Epigastric pain, don't always say that it is acidity. It is because of liver capsule stretch. She is probably getting into HELLP. A woman coming to you with frontal headaches and occipital headaches is not hypoglycemia or hungry or acidity. She may be having symptoms which are suggestive, because sometimes blood pressure may be normal, but the patient would still have symptoms. Headache is found in 66% of the patients, visual disturbances 27%, and epigastric pain in 25% of the patients. So this is most common and easily identifiable complication. Antepartum is the most common type, about 38 to 53%, intrapartum 18 to 36%, postpartum 11 to 44%. And there can be atypical eclampsia. I have seen about 2 to 3 cases in my lifetime. When they occur less than 20 weeks, convulsions despite adequate magnesium sulfate can be there. And 48 hours postpartum also, patient can come to you with what is called as late postpartum eclampsia. And the seizures, when they occur, the first thing is treat them with magnesium sulfate. Don't look out for something else, no diazepam or anything. Please immediately give magnesium sulfate, because magnesium sulfate not only prevents the convulsion, but it also aborts the convulsion. And of course, with that, we have to give some supportive care, to which we are coming. Very important good news is eclampsia can be considered as a completely preventable disorder in many of the cases. And if you encounter any such case, it's always better to do reverse engineering and try to find out why did this occur, and we can improvise our services in the subsequent patients. Now, what has happened is eclampsia was a terrible disease long time back, before 2002. But after that, a MAGPIE trial got published in the Lancet. And from that time, magnesium sulfate came in our lives. I remember I was a JR1 that time, and Sneha and I have been trained together in Vijay Medical College and Sassoon Hospital. And we were those trainees who first used magnesium sulfate from our JR ship. And then we became proficient and very confident using it. And I think that fearless use of magnesium sulfate is an answer to prevent eclampsia. Let us look at this incidence which is happening here. This is a small little video recording which can just show you that how a patient can present.
Doctor, I have headache since morning. Okay. Doctor, she's 8 months pregnant. She hasn't eaten anything since today. Okay. I'm also feeling nauseous and also had one episode of vomiting. Okay, just take her BP meds. Let me.
So you can see that she's come with this symptom. She's just pregnant, and you can see she's saying headache, vomiting, feeling unwell, and her blood pressure is measured and it is found to be 170 by 100. So this patient already had a history of PCOD. She became pregnant with ovulation induction, and she had uneven course till now, till 33 weeks of pregnancy. But now her BP got recorded to 170, 100. Immediately the consultant say, please lie down, because we now need to see you. And you can see that immediately she was made to lie down, and she has thrown a convulsion. So you can see that headache, epigastric pain, nausea, vomiting, feeling ill and sick is a very important symptom. And if you are not able to give her magnesium sulfate intravenously, because the patient is very, very rowdy, then you may consider giving, that's what the doctor is telling, that you can put 2 grams of magnesium sulfate intramuscularly quickly, and then that will also help in aborting the convulsion. So always keep these magnesium sulfate boxes ready, because you may require issues. And the moment a patient encounters a convulsion, you must typically give her a rapid care, because this is a life-threatening situation which requires something like a blue code kind of an action. And we in our center have a blue code for all such things. Eclampsia happens to be one of the reasons why we initiate a blue code. And the patient is immediately given restrictive supportive nursing. So immediately when there is an eclampsia patient, at 0 to 5 minutes, airway, lateral decubitus, suction, oxygenation, restraint and care and protection. Secure her IV line with 18 to 20 gauge intracat. Deliver 4 grams of magnesium sulfate over 5 to 6 minutes. 4 ampules of 50% weight by volume plus 12 milligrams. 12 ml of distilled water can also be given, or you can just put it in 100 ml. 100 ml normal saline, you just put in 4 grams of magnesium sulfate and deliver it over 10 minutes. That also can be done. Or and now we have one company which has come with a formulation where they use 4 grams of magnesium sulfate, which is already predisposed. I'm going to show that picture, and that can be used and kept ready all the time so that you don't have to break the ampoules. Take the samples at 10 to 15 minutes for blood and urine for testing, antihypertensive treatment. If she's conscious, you can give her oral nifedipine, 10 milligram, a slow release formulation. Don't give any sublingual, or you can even give labetalol 200 milligrams. It helps. And if the patient is unconscious, then give labetalol drip. Magnesium sulfate infusion, 24 ampules of 50% withdrawn in 50 ml syringe, attached to the syringe pump 1 gram per hour. I'm going to show how it is attached to the syringe pump. Pritchard's intramuscular regimen of loading dose 5 gram in each buttock has been recommended by all over Government of India, WHO, everybody. But we are quite well versed now with giving IV regimen, and you can consider giving that, especially in our special facility cares. We can definitely give it because it's very easy to monitor and deliver and causes less pain to the patient. And assess the patient's history quickly, obstetric parameters, then gestational age, fetal status, Doppler, NST, and the Bishop score, because we have to deliver this patient. Now, non-stress test is something which is done so that you know what is happening, but also don't forget to interpret it correctly, especially in a preterm baby. And during a convulsion, patient may show certain changes. That doesn't mean that you must quickly go and deliver the baby. Just give it some time, give her some oxygenation, the baby will recover. And order for sonography with Doppler if that is possible. At 15 to 20 minutes, procure the lab reports, fetal assessment, and plan the delivery. Now, when the patient becomes stable, you can consider delivery or based on her obstetric parameters, how you are going to deliver her. And you can consider her transfer to the HDU ICU facility. We in our centers do management of these patients in an HDU facility. And most of our labor room nowadays are like HDU facilities, and you can very well treat her there. If there are recurrent seizures occurring, then you can repeat the 2 gram bolus after the primary 4 gram has been given. Refractory seizures, you can consider lorazepam. And deeply unconscious patient, you may have to consider intubating this patient. So this is how the drug can be delivered by an infusion pump, which you can see here.
I'm going to show you how to administer injection MgSO4 via an infusion pump. First, I have dissolved 5 gram of injection MgSO4 in 50 ml. Hi, today I'm going to show you how to administer injection MgSO4 via 5 gram of injection MgSO4 in 50 ml of NS. Now I'll be installing this 50 cc syringe in the infusion pump in this manner. Now once the syringe is installed, it will automatically show an icon where you will just have to press OK. And no drug. Again, you will have to press OK. Then you will have to adjust the dose. In this case, we'll have to administer dose as 10 ml per hour. So I'll just increase the dose as 10 ml per hour. And I'll just have to press start. And the drug is ready to be installed. Thank you.
So you can see that here, you can very well give it with an infusion pump. So your hands free to do the rest of the monitoring and management of the patient. One has to remember that once the magnesium sulfate has started, it has to continue for 24 grams till the patient has delivered or from the last seizure convulsion. So accordingly, you have to take a call. And the contraindications are pulmonary edema, renal failure, and myasthenia gravis. And this is the contents of the magnesium sulfate box, which you should always keep ready, so that when the patient throws a convulsion, you don't start looking for things. They should be there in the magnesium sulfate block, importantly. As I mentioned at the outset, that you can use magnesium sulfate for avoiding the convulsion because it has very wonderful actions. It blocks the NMDA receptors, reduces presynaptic release of neurotransmitter glutamate, potentiation of adenosine action, improved mitochondrial calcium buffering, and blocks the calcium entry via voltage-gated channels. And it therefore, in the run, starts helping in improving perfusion, not only of the brain, but also of the placenta, and it has wonderful advantages. Now, world over, so these are just a pictorial representation of what I said just now. And world over, you can see here in the United States of America, they have a preload thing. Why go to US? Even Bangladesh has such a kind of a thing. In our country, however, we do not have a pre-mixed medication. There are a lot of issues with the DCGI. But we now have the 4 gram, as I told you, in 100 ml, which I'm going to show you a picture. Because why it is important? Because study has said that many times error is found in the administration of the drug. A lot of fear is found in the administration of the drug. And that is the reason why probably we are having resistance for eclampsia being controlled. So therefore, we can see that this is the ready-to-administer solution, which will resolve the errors in dosage calculation and associated complications, where you have 4 grams already pre-dispensed in 100 ml. And it has been found that very simple things have to be looked for whenever you're doing magnesium sulfate infusion, continuous CTG monitoring if more than 26 weeks of gestation, maternal observations such as respiratory rate every 30 minutes, BP monitoring every 30 minutes, maternal pulse hourly, urine output hourly, reflexes at the completion of loading dose and every 2 hours, and measurement of serum magnesium sulfate levels is not necessary unless there are signs of toxicity. So what are the signs of toxicity? Respiratory rate less than 10 minutes or SpO2 less than 90%, evidence of muscle paralysis and complete absence of reflexes. If toxicity is subjected, you can immediately cease the infusion and take blood for magnesium sulfate level if you wish. And treatment of toxicity is administer calcium gluconate 10% IV over 10 to 20 minutes. And always remember these therapeutic range. Now, the therapeutic range is 4 to 7 mole equivalents per liter. The platelet patellar reflexes will be lost at more than 7. So if your patellar reflex have gone, that means you know that you have achieved the therapeutic level. Simple. So patellar reflex are not there, your magnesium sulfate is adequate. Now keep on looking at the respiratory rate. Respiratory rate, if it is falling less than 12, then she's going into respiratory paralysis. You may have to modify her subsequent dose and keep a watch on her. And if the magnesium sulfate becomes more than 30, then the patient may more than 25 mole equivalents, she will have cardiac arrest. So whenever there is any kind of a suspicion of a toxicity, you can very well give her calcium gluconate. And many large trials have continued telling us only this, that you have to use magnesium sulfate effectively. And also nowadays, we know that for the past decade, we are talking of using it prophylactically.
Take a BP once. And her BP in the morning was also 160 by 100. Should we give her magnesium sulfate? Yes. Get the infusible box. We will give her injection infusible 4 grams as a prophylactic dose.
So you can see that a patient comes to you with hypertension, immediately give a magnesium sulfate so that you can prevent a convulsion, and don't worry, it has advantages. Even if you have given a magnesium sulfate, that doesn't mean when you have given it for prophylaxis, that doesn't mean you have to immediately deliver the patient. Look at her other parameters. There have been situations where we have been able to continue pregnancy till 34 weeks in this patient when magnesium sulfate was given, and it wasn't essential to deliver these patients. So the question, however, unanswered is whether we give a full dose or a loading dose, but the practices which are followed by many organizations, and we also follow in tandem, 1 gram of magnesium sulfate given over 24 hours for prophylaxis, similar to the tocolytic dose, is what is recommended. So expected management can be considered in this patient who has not had a convulsion, and you are buying some time because the baby is very small or premature, and therefore do not always induce a delivery in this patient. Now, you can have a situation where the patient has been brought in unconsciously and she is throwing the convulsion. And typically, then we wonder what is wrong with this particular patient. And you would like to look at various differentials, whether there are there, like cerebral malaria, meningitis, or encephalitis, tetanus, or anything. But always remember that any convulsion during pregnancy is always epilepsy. And any patient who's brought in always eclampsia. And any unconscious pregnant woman brought to you is having eclampsia. So various differentials would come to your mind, like syncope, stroke, intracranial hemorrhage, hypoglycemia, and cerebral malaria. Now, I want an audience to pay your attention and put it in a chat box and answer. Look at this particular situation and please write in the chat box, what is the phase of the convulsion? Anything that you want to talk about the gag, position, and suction. What is not there? What should have been done? So you can see that it is a very terrible thing. And when you're putting these mouth gags, it is very important to put them because we want to prevent tongue injuries. And you can see such terrible kind of things can happen at the outset. After 72 hours and after 7 days, this woman has shown such a bad, macroglossia which occurred to her. She required an intubation because the mouth gag wouldn't fit into her. Just imagine how many seizures she must be having. So seizure phases are typically tonic phase and the clonic phase. And they would be followed by a post-ictal phase. And the moment you see a seizure, I told you that you have to ask for help and activate the code blue. And eclamptic convulsions are life-threatening emergency that should be cared in proper manner to minimize morbidity and mortality. So this should be the ideal nursing position of the pregnant woman with eclampsia. You can see that she is a semi-propped up position, left lateral, and NST strapped, IV and everything is on. There's a multipara monitor which is attached, and she is having an infusion pump by the side and is being closely monitored. This is a picture from our labor room in Bharti Hospital. And we have a dedicated eclampsia room. You can see how well it is. And this is where we start giving them first. So first you give the maintenance dose, as I told you, 4 gram, followed by putting it on the infusion pump. And at the same time, you are going to take her blood labs for testing, and you are going to also place in a urinary catheter. Now, immediate actions we have already discussed, so I will not waste my time onto here. Always keep this kind of a checklist ready, wherein you are calling for help. You are seeing that all the things are done, which I have been talking just now, and designate the team leader, left lateral plus gag, propped up, magnesium sulfate, ensure side rails are up, protect airway plus improve oxygenation, continuous fetal monitoring, place IV, drop E labs, administer antihypertensive therapy if appropriate, develop a delivery plan, and debrief patient, family, and the OB team. There are minor side effects when we give magnesium sulfate, like nausea, vomiting, muscle weakness, thirst, headache, drowsiness, and confusion, but they are many times transient. And you must monitor the mother and the baby diligently. Maternal blood pressure monitoring would be every 10 minutes for 1 hour. Try to achieve a blood pressure control of less than 150/100. And every hour for 4 hours, baseline labs have to be sent for the mother. And fetal surveillance can be done by NST, and if necessary, if the baby is premature, you can do a Doppler as well. Laboratory investigations, all the preeclampsia labs include hemogram, urine examination, liver enzymes, including LDH, renal function tests, platelet count, serum electrolytes, PBS if it is available, to look for schistocytes, which will tell you about hemolysis. But if that's not there, you can rest upon LDH. And when the LDH levels are abnormally high, that is more than 600, then probably she's going into hemolysis as well. And fundoscopy if it is possible. And thus you have to have the patient, as you can see here in this position, follow checklist, the Muse chart, which I'm going to show you an excerpt about, monitor the patient, put an airway, gag, breathing, PO2, circulation, pulse, BP, FHR, drugs, magnesium sulfate, labetalol, nifedipine, and E is expose and explain. So this is the PERT chart, which I feel is much more optimum rather than the general Muse chart, which is used for obstetrics, which is preeclampsia early recognition tool, where you are assessing the patient's various parts like awareness, headache, vision, systolic, diastolic blood pressure, respiratory rate, pain, abdomen or chest, fetal signs, urine output, etc., and the labs as well. And you can see here whether it's green, yellow, or red, and then accordingly we scale up our care for the woman. If convulsions recur, then you're going to repeat the 2 grams as I mentioned to you. And other anticonvulsants which can be used are lorazepam 2 to 4 milligrams IV into 1, may repeat after 10 to 15 minutes. Phenytoin can be given. So all these dosages, you must keep them printed so that at the last moment, you're not supposed to think and calculate. Phenytoin 15 to 20 milligrams per kg IV into 1, may repeat 10 milligram per kg IV after 20 minutes if no response. Avoid if she has hypotension or any cause of cardiac arrhythmias. And Keppra is another advanced seizure medicine which is used. And this is done, dose adjustments of all these are necessary if the woman is having creatinine, which is more than 1, because that is showing that she's having a renal excretory impairment. Now, if the patient has respiratory depression, then stop magnesium sulfate, give calcium gluconate, give oxygen by mask, maintain airway, and give her the recumbent position. I've already demonstrated to you. Stop magnesium therapy, give 1 gram calcium gluconate, and you may need to, if she's gone into respiratory arrest, then you may have to intubate and ventilate immediately. And ventilation should be continued until the resumption of normal spontaneous respiration. I would also make a recommendation that each and every member of the AMOGS here has to train themselves in adult life support workshops. And if you are really interested, you can contact me and we can organize a workshop for you in our Bharti hospital. We have an excellent high level of simulation lab, and we can definitely help you to learn this BLS or ALS you must learn. So urine output, if it is less than 100 ml in 4 hours, then if there are no other signs of magnesium toxicity, the next IM dose of magnesium to be reduced to 2.5 milligram, or the IV infusion to 0.5 gram per hour, and particular attention to be paid to fluid balance and blood loss of the woman. Very, very important to look for risk stratification and complication management. CNS, look for pulmonary edema or cyanosis, epigastric or upper quadrant pain, impaired liver function, thrombocytopenia, hemolysis, coagulopathy, oliguria of less than 30 ml per hour for 2 consecutive hours, and prompt evaluation and communication if undelivered, plan for delivery, and look at the fetal growth restriction and abnormal fetal tracing. Now, once the patient status is stabilized, then you may consider delivery, and the timing and the route delivery after stabilization. HELP and severe preeclampsia require delivery. You are not going to sit on them. And maternal blood pressure, continue control with oral agents, and the target blood pressure, as I mentioned, has to be 140 to 150 to 90 to 100. Special delivery decisions include if the baby is preterm, then give antenatal steroids, subsequent pharmacotherapy. Factor for HELP, you have to investigate. HELP is always a laboratory diagnosis, and you may consider delay of delivery for 24 to 48 hours for stabilizing the fetal condition and the maternal condition. Do not hastily get her into a labor. You may land up in more complications. Contraindications to delay in delivery for fetal benefit of corticosteroids will be uncontrolled hypertension, eclampsia, pulmonary edema, suspected abruption, disseminated coagulation, non-reassuring fetal status, and intrauterine fetal demise. Be careful with your fluids. Don't push them, because after delivery, many times oliguria is quite common. It's less than 15 ml per hour and does not need aggressive treatment, because if you push fluids, she is at risk of developing pulmonary edema, and your total fluid should be restricted to 80 ml per hour. That is 1 ml per kg per hour is beneficial. And therefore, I always advocate using infusion pump for delivery of magnesium sulfate, because even labetalol to be delivered through infusion pump is a better idea, so that you don't give unnecessary fluids to this woman. Because pulmonary edema is a very important cause of maternal death in these patients, because these women have fragile capillaries and there is always a risk of having issues. And then postpartum surveillance is important. You can see that this woman is all ready to go home after delivery.
Are you ready to go home? How's the baby? Baby is fine now. And since you had high BP before delivery, so if you have blurring of vision, headache, nausea or vomiting anytime, then report to the hospital urgently. Yes, doctor, I'm having headache right now. Get the BP app.
You can see that this patient has not ready to go home and she's thrown a convulsion. So postpartum surveillance is extremely important. Measure blood pressure every 4 hours after delivery until stable. Do not use NSAIDs for women with elevated blood pressure. Do not discharge the patient until BP is well controlled for at least 24 hours. And outpatients, you have to give them warning sign recommendations. And for patients with preeclampsia, visiting nurse evaluation can be done, or you can ask her to go to a local general practitioner who will keep her BP record and report to you whenever it is raised. Again, call her back in 7 to 10 days after delivery, because there can be certain early or persistent symptoms. Antihypertensive therapies can be continued for a longer. Usually, if it's a pure preeclampsia, not superimposed, by 6 weeks, they do not need any antihypertensives. But most of our patients currently have superimposed eclampsia, so they may require antihypertensives for 6 months post-delivery. And this is something that we all have to remember and practice. Always be up to date with everything that is going to be required for eclampsia. And so this can be your labor room with a well-equipped room, oxygen, maternal neonatal resuscitation facilities, eclampsia kit protocols and documentations in place. And your eclampsia kit and magnesium sulfate box should always be ready, refurbished at the beginning of the month or the end of the month, whatever your protocol and an SOP in your facility can be, but it is very, very important. There are certain questions which we still have to answer, and they are: determine the optimal duration for magnesium sulfate prophylaxis after delivery for women with preeclampsia with severe features, and assess whether women presenting with late postpartum preeclampsia with severe features more than 48 hours after delivery will benefit from magnesium sulfate prophylaxis or not. Thank you so much for giving me this time and the opportunity. I hope I have been able to answer all your questions. And I'll just look into the chat box whether there have been any answers here. Okay, somebody has written only gag not in position. There were so many things which are not in position. One, the patient should have been in a propped up position. She should have been in a left lateral position. Always there has to be respectful maternal care. She should have been covered properly. And then there should have been, restrictive nursing. Means she should be restricted, but with care, and not generally allowed to be, she would have fallen down. There was nobody holding her. This is not how we must do. We must help these patients when they are throwing a convulsion. Thank you so much.
Thank you so much, madam, for your comprehensive talk. You left nothing, everything is covered regarding eclampsia. I request the chairpersons to give inputs.
Yeah.
Dr. Ganesh.
Yes, thank you, ma'am. Thank you for the nice lecture, ma'am, covering every points of pregnancy PIH, including pathophysiology, diagnosis, and most important the management, and most important the postpartum management of the patient. And clear, what I meant to say clearly, it focuses on how to prevent and a role of magnesium sulfate, the management of PIH patient. Thank you, ma'am. Thank you very much.
Yeah, before I leave the screen, I want to congratulate and appreciate Sneha and want to make an appeal on behalf of all of us that we have to vote for her large numbers and ensure that she wins the vice president of this time.
Thank you. Thank you so much, my dear. I was about to appreciate you. It is always, it is always a pleasure to listen to you, and it was such an amazing lecture. It is a lecture. I won't say it was a talk. It is a lecture to teach, every point you have covered, how a patient of hypertensive disorders, should not get into eclampsia, how you can prevent it. Once it goes into eclampsia, how you have to manage it safe-wise. If at all she develops toxicity, how you have to tackle the toxicity of magnesium sulfate. Everything has been covered very well. And as rightly pointed out, that every conversion, damages the brain further. So we as obstetrician has the responsibility to prevent the eclampsia under observation. It is our duty to see to it that we prevent eclampsia. So thank you so much. So many take-home messages from your talk, Girija. Thank you so much for accepting our invitation, and thank you. Thanks for everything. Over to you, Chairperson.
Yes,
Yeah.
Thank you, chairpersons, for the session. And thank you, Girija ma'am. Over to Dr. Monica for session 2.
Thank you, Dr. Madan sir, for conducting this session so nicely. Girija ma'am, your talk was as elaborate as it could be. We now move forward to the second session, which is hyperglycemia in pregnancy, and I would like to invite the chairpersons for the same. Our first chairperson is Dr. Lalita Swami Madam. She is a director at Swami Hospital, Osmanabad. She has been working at the same hospital for the last 15 years. Currently, she is the president of Osmanabad Society and the president of the Women's Doctor Wing, IMA Osmanabad. We welcome you, ma'am.
Thank you.
Sorry, excuse me. Our next chairperson for today, Dr. Sudesh Doshi sir, is currently a senior obstetrician and medical legal consultant working since the last 25 years at Pandharpur. He has an experience of delivering more than 15,000 babies in the rural setup.
Monica, you can relax for a moment. Monica,
Yes,
I would introduce Sudesh Doshi, the senior obstetrician from Pandharpur, and of course, a medical legal expert, the chairperson of Adolescent Health Committee from 2016 to 18 for AMOGS, and of course, the zonal coordinator for AMOGS. Of course, our BJ alumni. We're very happy to have you, Dr. Sudesh. Over to you for introducing the speaker.
Thank you, ma'am. I request Lalita ma'am to please introduce Shula madam.
Thank you, ma'am. Thank you. Good evening, everybody. Firstly, I am very thankful to the AMOGS Emergency Committee for such an important webinar. Today's topic of hyperglycemia in pregnancy by Dr. B.S. Sushila Rani. Dr. B.S. Sushila Rani, MD, PGDM LE, FICOG, Director and Consultant of Manjushri Specialty Hospital, Chairperson, Postgraduate Forum, Bangalore, OBGYN Society, past President of Bangalore Society of OBGYN, past Chapter Secretary, IMS, Bangalore Chapter. I request ma'am, please start the session.
Thank you. At the very outset, I would like to thank Dr. Sneha Boyar for inviting me, and I just see, make sure this. Are you able to see my screen?
Yes, yes.
Yes, ma'am.
Yeah,
That's all. Yeah,
and
perfect.
thanks to both Pandharpur and Osmanabad Society, Dr. Lalita Swami, Dr. Sudesh Doshi, and to all the seniors who are present. I will straight away jump into my topic because I don't want to delay any more. Dr. Sneha asked me to talk about the management of hyperglycemia and pregnancy, and that would mean a lot to be covered in 20 minutes. So I thought I'll restrict to the management of hyperglycemia and pregnancy. I will leave out the obstetric management, and if there are any questions, I'll be more than happy to answer with regards to obstetric management of hyperglycemia and pregnancy. Now, you must understand that the pattern of glycemia in normal pregnancy is very, very different from the pattern of glycemia in a non-pregnant woman. In a normal pregnancy, you will find that the fasting blood sugar is somewhere around 71 milligram. 71 milligram, which probably otherwise you would think of hypoglycemia in a non-pregnant person. And at 1 hour, the blood sugar is around 122. And at 2 hours, the blood sugar comes down to 110. So it is very, very obvious from a survey of the glycemia of normal pregnancy in thousands and thousands of women that the sugars are much, much lower during pregnancy than in a non-pregnant person. Now, having said that, we need to decide what are the targets we want to achieve to say that this is our glycemic control. Now, we need to make sure that the fasting plasma sugar is anywhere between 80 and 90, and the 2 hours post meal is between 110 to 120. So maybe 120 maximum and 90 fasting. These are the targets that we need to keep in mind. Now, when we maintain these targets, we'll find that the birth weight is anywhere between 2.5 to 3.5 kg, and that would be the ideal weight. Now, to bring the glycemic control, there are three things that we need to do. We realize that as the pregnancy advances, there is an increasing insulin resistance, and the secretion of insulin also can be a little deficient in those women who have hyperglycemia in pregnancy. So if we need to bring the sugars under control, we need to either increase the insulin production, or we need to decrease the glucose load, or we need to decrease the insulin resistance. So we need to do either of these three or all of the three in order to bring the sugars under control. How do we go about doing that? Increasing insulin can be done by giving insulin from outside, or by giving glyburide. Glyburide increases, it's a secretagogue, it increases the insulin secretion. How do we decrease the glucose load? And that is by making modifications in the diet. I will talk about it in the next couple of slides. How do we decrease the insulin resistance? And that is by exercise. Now, you'll want to know how exercise decreases the insulin resistance. Exercises increases the uptake of glucose by the skeletal muscle and thereby brings about a decrease in the insulin resistance. Metformin is a biguanide. It doesn't increase insulin production, but it decreases insulin. It increases the insulin sensitivity, and therefore it works very well during pregnancy. Now, when we look at the prescriptions, the non-pharmacological things are diet modifications and exercise, and that is what we call as MNT. Now, what diet modifications are we talking about? We need to reduce the grain size. That means no going beyond 2 numbers of idli, dosa, roti, chapati, and they should not be too big in size either. No going beyond 1 soup bowl size of either rice, upma, or poha. And the frequency and time also needs to be kept in mind. We need to have 3 small meals. Now, when we say 3 meals and 3 snacks, they tend to make it as 3 major meals and 3 snacks, which is not okay. They need to reduce the quantity of the meals and introduce 3 snacks in between so that the spike in the blood sugars are reduced. And protein source need to be increased, and that would be in the form of paneer, soya, dals, lentils, sprouts, boiled groundnuts, seeds, eggs, chicken, small fish, and milk, of course. Now, the things that need to be avoided during pregnancy or even otherwise would be bakery items, packaged foods, and biscuits. We need to increase fiber. It's very important to increase fiber in pregnancy because the fiber binds the glucose and doesn't allow it to be dissipated, and therefore doesn't bring about a spike in the blood sugar. So include maximum non-starchy colored vegetables, and that brings about an increase in fiber. Now, we must understand that Indian meal, whichever region you go to, north, south, east, west, it's very high in carbohydrates and low in proteins. So every meal should contain protein. Every meal should contain at least a substantial quantity of protein. And this is the way we can change. Increase protein in the salads and increase protein in the main meal as well. So like I said, if you have to sit in the OPD, you cannot be talking a whole lot about the diet, but definitely this is something that you can talk to your patients about. This is called the plate method to portion out meals. If you take an 8-inch plate, half the plate should be of vegetables. And these are non-starchy vegetables. The more the color in the vegetables, better. Quarter plate should be protein, and that protein can be in the form of dal, fish, chicken, whatever. And quarter of the plate only should be starch. So we cannot have 3-4 rotis and a very small quantity of sabji. So it should be half the plate of sabji and quarter plate of protein and quarter plate of starch. Now, that's about diet in pregnancy. What about exercises? 30 minutes of moderate intensity activity is recommended. Exercises can be aerobic and low resistance exercises. 15 to 20-minute moderate activity after a meal helps to keep the sugar level within the target range. And preferably upper body low resistance exercises are recommended. If somebody is going to the gym and they want to exercise, then it would be preferable to do the upper body low resistance exercises. Any lower body exercises are not preferred because they tend to increase the abdominal pressure and may precipitate uterine contraction. So if we are going to look at prescription of exercise, then we talk about aerobic walking, aquatic activities. These are very few people actually who go into all these things. Weight training for arm muscles with half to 1 kg weight. And the intensity should be mild to moderate, duration of about 30 minutes per session. There should be a warm-up and cool-down session. At least 150 minutes of activity should be spread throughout the week. Now, this is when you're talking about exercise to your patients. Simple exercises like wall squats, that is, they sit against the wall with the legs at right angles, and this kind of wall squats, etc., and wall push-ups, and weight training for the upper limb, just holding a 1 liter bottle or a half a liter water bottle in both the arms and lifting the arms up, that itself can go a long way in the form of exercises. Now, we find a lot of women who are pregnant working in the IT sector. Even if they are not in the IT sector, a large time is spent in front of a computer. So their activity is largely sedentary. And this kind of sedentary activity confers about 3.8 odds ratio for adverse neonatal outcome in GDM pregnancy. So encourage moving and ask them to keep moving all day. This is a definite recommendation. Now we'll come to the pharmacological prescriptions, and that would be in the form of insulin, in the form of metformin and glyburide. Anti-diabetic agents are insulin, metformin, glyburide and acarbose. Glyburide and acarbose, I will come to that. Now, way back in 2015 itself, it was decided that glyburide treatment is associated with increased risk of maternal weight gain, macrosomia, increased NICU admissions, and neonatal hypoglycemia and respiratory distress syndrome. So glyburide is out. There is no more glyburide prescription during pregnancy. The next drug that we could think of is metformin. Metformin, this is a recent article which in May 2021, which says that metformin is comparable to insulin for pharmacotherapy in gestational diabetes mellitus. A network meta-analysis of evaluating 6,046 women. This is quite a number. And this particular review, I would want all of you to go through this review, which is in Frontiers of Endocrinology, Lights and Shadows on the Use of Metformin in Pregnancy. We use it left, right, and center. We should know how safe it is from preconception phase to breastfeeding and beyond. Now, the effect of metformin on the mother, of course, it decreases miscarriage risk. It is identical preeclampsia risk. It neither increases nor decreases preeclampsia. Identical cesarean birth when compared to insulin. The gestational weight gain when metformin is used as compared to insulin, weight gain is much reduced. What is the effect on the fetus? The congenital anomaly is very much the same as insulin use. Identical preterm birth. Sometime back, it was thought that it can cause preterm births, but then, subsequent studies have showed that it doesn't increase preterm birth, identical birth weight and height, but the long-term effect of the metformin, as the child grows, it's been shown that there increased adiposity is there in mothers who received metformin for managing their hyperglycemia. The government of India prescribes metformin after 20 weeks of gestation for medical management of GDM. The dose of metformin is 500 milligram twice daily. You can increase it up to 2 grams per day. And most important thing that you need to remember is metformin is one tablet that is given after a meal. So 500 milligram twice daily, increase it to 1,000 milligram twice a day if required, and it is given after a meal. Now, which are those patients who do well with metformin? The ideal candidate would be a person who's got a fasting plasma sugar less than 100. That means just about diabetic. Later gestational age at the time of treatment, you find that her sugars are high when she has reached already 34, 36 weeks. And the sugars are just slightly high. There is no previous history of GDM and lower BMI. This is not a very obese woman that you're looking at. Such patients form ideal candidates and they can be managed very well with metformin. Advantages are lack of maternal hypoglycemia. Metformin never causes hypoglycemia because it's an insulin sensitizing agent and it does not secrete insulin from the pancreas. It's simple, easy to administer, and more acceptable. Patients who are more likely to require supplemental insulin, that means not so ideal candidates for metformin. Even if you do give metformin, sometime or the other, they will need supplemental insulin. And these are women who have a fasting plasma sugar of more than 110 or very early gestational age at the time of treatment. Say you found that she is diabetic at 24 weeks. And then she's got a long way to go to deliver. And these are patients who would benefit with insulin. And even if you do give metformin, they will need insulin subsequently. Diagnosis of GDM in previous pregnancy, definitely they will need insulin. And very obese woman, that is a BMI more than 35. Now, for a long time, the traditional management of diabetes in pregnancy was diet, exercise, and insulin. Insulin is the gold standard, continues to be the gold standard in the management of hyperglycemia and pregnancy. Metformin has only made a recent entry for various reasons. Now, when do we start insulin in GDM? So at diagnosis, now when you do diagnose, you put a patient on MNT, but if the sugars are very high at that point of time, you straight away start them on insulin. You don't wait for the MNT to act and find out if the sugars are under control. Straight away, along with MNT, if the fasting plasma glucose is more than 120 or a 2-hour plasma glucose is more than 200, then this is a woman who has got pre-gestational diabetes, and you would want to start insulin right away along with MNT. Or if the sugars are just moderately high, the fasting plasma glucose is just about more than 90 after MNT, and if the 2-hour plasma glucose is more than 120, in those cases, after MNT, if the sugars are not coming under control, then you start them on insulin. Now, what is the insulin requirement in pregnancy? For theoretical purposes, first trimester 0.7 units, second trimester 0.8, third trimester 0.9 units per kg per day. At term 1 unit per kg per day. So if she is about 60 kg woman, we would have to distribute the insulin depending upon her body weight. Now, 2/3 of the insulin is given in the morning and 1/3 is given in the night. Gestational, if it is, that is in women who have got pre-gestational diabetes. In women who have got gestational diabetes, the requirement is variable depending upon the time of onset of diabetes and the severity of hyperglycemia. So depending upon, when you pick up this one. So the insulin regimes that is given is, in a woman who has got gestational diabetes, that means diabetes that has been picked up because of increased insulin resistance of pregnancy and which is picked up sometime after 24, 28 weeks. These women need only once daily insulin. If the fasting blood sugar is high, then probably you want to give them twice daily insulin. Premix insulin is most convenient. Premix insulin is a mixture of both the regular and the long-acting insulin. So you give a mix of regular and long-acting. The regular covers for the meal that is immediate, and the long-acting covers for the blood sugar that happens after the meal, for some time after the meal. Now, in type 1, if women with type 1 diabetes or type 2 diabetes become pregnant, then they probably will need at least 3 injections of insulin every day, along with breakfast, along with lunch, along with dinner. Apart from that, they will need a long-acting insulin at bedtime. So this long-acting insulin is, it doesn't produce an insulin spike. It is it has got an action for almost 18 to 24 hours, something like glargine, etc. So that will take care of the basal insulin production, and the small doses, the bolus insulin that we give, will take care of breakfast, lunch, and dinner. So this is something that we need to remember while giving insulin mixtures. Now we have Mixtard, which is 30-70, that is 30 regular, 70 isophane. 50-50 is 50 regular, 50 isophane. Multiple injection regimes, like you can give Mixtard in the morning and with breakfast and with supper, or you can give regular insulin and Mixtard only in the night. So this will take care of the fasting sugars also. So you can give regular and intermediate insulin at bedtime. Now, for example, this woman has got a fasting of 85, breakfast is 155, lunch is 145, and dinner is 140. All these are more than 120. So this is a woman who will definitely benefit with bolus insulin. Since fasting is okay, we need to give only 6 units of regular insulin before breakfast, before lunch, and before dinner. So that is how we decide on how we give the insulin. How do we adjust the dosage and how do we achieve control? Titration of the dose is based on the self-monitoring of blood glucose values. If the fasting is high, more than 90, increase the night dose by 2 to 3 units. If the 2 hours post-lunch is more than 130, then increase the morning dose by 2 to 3 units. In case there is hypoglycemia, that is, if the blood sugar falls to 60 or so, reduce 2 units both time. That is, hypo occurs if food is delayed or if insulin is more. Now, this is a woman who is receiving 8 units of Mixtard 30-70 before breakfast. You will find that despite that, the fasting is okay, post-breakfast is okay, post-lunch is also okay, but the post-dinner is a little on the higher side. So along with 8 units Mixtard before breakfast, you will add 6 units of regular insulin at dinner. This will bring down the post-dinner sugar values. Now, a word about insulin analogs, that is, these are synthetic insulins or recombinant insulins. The advantage of this recombinant insulin, now this is the insulin, regular insulin, and this is the recombinant insulin. You will see with the regular insulin, if there is a spike in the blood sugar, it takes time for the peak to be achieved. It takes about 1.5 hours for the peak to be achieved. So there is a period when the sugars can be high because the peak is achieved only little late. And there is but it continues to be in the system for a longer period of time. That is, even after the blood sugars have come down, insulin continues to act. So there can be a period of hypoglycemia here and a period of hyperglycemia here. That can be corrected by giving a recombinant insulin. The advantage of recombinant insulin is the rise in insulin, the peak of insulin is similar to how it is in the human, how it is in the body normally. Normally, when we take some food, there is a spike in the insulin, and the spike and the peak of insulin matches the peak of the blood sugars. And that is what happens with insulin analog or the recombinant insulin. Better mimicking of physiological insulin secretion. It's got a better control of postprandial blood glucose values and a better control of glucose levels in the fasting and in between meals, interdigestive period. Therefore, the risk of hypoglycemia is much less, and it's very predictable action. The best part of this is you can take the insulin along with the food, and you know for sure that it is effective in bringing the sugar under control, unlike the regular insulin, which needs to be taken half an hour to 45 minutes before taking food. If there is a delay in taking food, then there can be problem of hypoglycemia. So these are the insulin analogs. They are categorized as rapid acting and long acting. Rapid acting is Lispro and Aspart. Gluolicin is not allowed in pregnancy. Long acting is Detamir. Detamir is used in pregnancy, but Glargine and Degludec are still not used in pregnancy. If somebody is already on Glargine, then it can be continued during pregnancy. Now, when do all women need insulin analogs? Can't we do with our older insulin, that is the regular insulin? Because the recombinant insulins are quite expensive. And do all pregnant women who have hyperglycemia need recombinant insulin? No. We can do with the older insulin. There are only some women who have additional benefit by giving recombinant insulin. These are women with uncertain lifestyle, say air hostess, who is flying across the countries. There is no time set. So, and there is no quantity of meal is uncertain. So these are very busy people. They can do with insulin analogs. And those women where standard insulins are not controlling the blood sugars, or very high unpredictable fasting and postprandial blood sugars, or if some women do tend to have hypoglycemia, especially nocturnal hypoglycemia, they will benefit with recombinant insulin. Now, where do we give insulin during pregnancy? First trimester, there is no change in insulin site or technique of insulin. The woman has to take the insulin by herself. We need to teach her, and it is not any rocket science. She can take insulin on her own. Second trimester, it is given in the lateral parts of the abdomen, staying away from the skin overlying the fetus. Third trimester can be injected over the abdomen while ensuring the skin fold is properly laid. You take a pinch of this skin and then take the insulin. That is all that needs to be done. Insulin pens are now available. They provide convenience and ease of use and accurate dosing. Like when I say 5 units, only 5 units are delivered. 31G pen needles and shorter needles, they overcome some of the barriers for insulin use. It's very simple, absolutely painless to take insulin through these pens. Acceptability of insulin has therefore increased because of insulin pump. Insulin pumps are also there. It is being used, but these are for women who have got type 1 diabetes or type 2 diabetes, where the sugars are not very well under control. And those who can afford, yes, insulin pumps make it very convenient. They check the interstitial fluid glucose levels, not the blood glucose levels. And they definitely make a lot of difference, but need not be given for all women. Now, how tight should the control be? The control should be so tight to the extent that the fetus no longer recognizes that the mother has diabetes. This would be the first step in the prevention of diabetes and obesity in the offspring. The fetus should never know, because once the mother's blood sugar goes up and the fetal blood sugar goes up, the fetal pancreas will start producing more and more insulin and all the attendant. You cannot undo that problem. Therefore, before the fetus realizes that the mother is diabetic, we'll need to make sure that the sugars are well under control. So that is how the control should be. Thank you for a patient hearing.
Thank you, Dr. Sushila. It was a fantastic overview of diabetes in pregnancy. You covered almost all the topics like MNT therapy, diet therapy, exercise, about the oral hypoglycemic agents which we have added like metformin, insulin analogs, then insulin pen, insulin delivery systems, about pumps, and also you covered the most important part that the fetus should not know that the mother has diabetes. So there would not be the maternal origin of the adult disease which we want to create in the next generation. So it was a very comprehensive, very to the point, and very crisp lecture. I had never heard such a crisp thought about diabetes in pregnancy. It was like going to my UG lectures, and thank you very much for revising me in diabetes. Thank you so much. Sir has some queries. Please, sir. You unmute yourself, please, sir.
Actually, the thing is that I want to talk about diet first. Instead of complicating the things, whatever madam has said is exactly correct. मी मराठीमध्ये सांगतो. आपल्याला फक्त एकच गोष्ट लक्षात घ्यायची आहे, सगळ्यांसाठीच, फक्त प्रेग्नंट लेडी ज्यांना डायबिटीस आहे, जेस्टेशनल डायबिटीस आहे त्यांच्यासाठी म्हणून नाही, तर सर्वांसाठीच आपलं नैसर्गिक डाएट खूप महत्वाचं आहे. आपण जरी आज सिमेंटच्या जंगलामध्ये राहत असलो तरी आपण जंगलामध्ये राहणारेच मनुष्य प्राणी आहेत. जंगलामध्ये राहिल्यानंतर आपण काय खाल्लं असतं तेच सर्वांनी खाल्लं पाहिजे आणि तोच सल्ला पेशंटला दिला पाहिजे. त्यावरती तुम्ही सर्वांनी विचार करा आपण काय खाल्लं पाहिजे आज जर आपण जंगलामध्ये असतो तर. पहिली गोष्ट. दुसरी गोष्ट, रोल ऑफ आयनोस्टॉल अँड लॅक्टाल्बुमिन इन जेस्टेशनल डायबिटीस. कालच माझं एक स्पीच झालं उस्मानाबादला, मी ग्रुपवरती टाकेन नंतर. तर आयनोस्टॉल आणि लॅक्टाल्बुमिन जे आहे हे दे कॅन बी गिव्हन बिफोर प्रेग्नन्सी, it can be given in first trimester also, and it can be continued till delivery. What is the role of inostols and lactalbumin? It increases the insulin sensitivity first of all, and thereby it decreases the requirement of insulin in pregnancy. So you can replace metformin with inostols and lactalbumin, so that the side effects of metformin you will not get, and lactalbumin, it is a simple protein, so there are no side effects. That's all. Thank you.
So can I say something here?
Yes, madam.
Inositol is a second messenger within the cell, where it is actually a cell messenger, and therefore it is not even considered as a drug. It is a nutrient for that matter.
Yes, ma'am.
But having said that, myo-inositol, inositol in general, and lactalbumin, these are natural products. It does help in bringing the sugars well under control in a person who is slightly glucose intolerant. But if the sugars are not well controlled, if they are going beyond 120, by themselves, myo-inositol and lactalbumin may not be able to bring the sugars under control.
Yes. Yes, ma'am.
You will need supplemental metformin or insulin to bring the sugars under control. I have done a study on myo-inositol, whether it can prevent gestational diabetes if it is given to all pregnant women. It did bring down the incidence of diabetes in pregnant women. We hardly saw any woman having hyperglycemia during pregnancy in that particular study, where we gave 2 grams of myo-inositol twice a day. But having said that, it is expensive, sir, to be given in the, if you are giving, in that particular study, we gave 2 grams twice a day. That is 4 grams of myo-inositol. Now, if you are to give that amount of myo-inositol, maybe it will make a lot of difference. But like you said, it is worthwhile giving in all women. It is a nutrient. It definitely doesn't cause any harm. And therefore, if it is given to women with gestational diabetes, it definitely helps to bring down the sugar levels and probably decreases the dosage of insulin.
Insulin.
Yeah, so that is how it is.
Ma'am, actually the thing is that because of presence of other sugars in the diet, and also in the preparation of inositol. The absorption of inositol is decreasing. There is development of inositol resistance. So we are adding lactalbumin in that, alpha lactalbumin, so that the inositols, they will be absorbed properly and they will work properly. That's why we are adding lactalbumin in this. And lactalbumin is full of all 9 essential amino acids that will help the mother and also the fetus. There will be no need of giving any extra proteins. So lactalbumin addition to inositols is a alternative for metformin, or it will reduce the dose of insulin. That's all.
I agree. Thank you.
Thank you, ma'am.
Supplementary therapy.
Yes.
Supplementary therapy.
Yes, your comments, Sudesh, first.
Yeah, actually, I have given the comments. It was really a good lecture. She has completed almost all the parts. And many times what happens is we as clinicians must emphasize on the diet and the exercise part, which we sometimes in our busy practice forget to tell the patients. And the other important part is when a patient is diabetic, whether she's pregnant or not, you should include the family members with them, especially her mother-in-law and her husband, because it is not only she who is going to guide her diet, because the food is not going to be cooked only for her. The food is going to be cooked for whole family. So the family has to understand that she has special dietary requirements, and accordingly the food should be cooked, because we don't say that this food will cook for herself, then this for her husband, and this for her in-laws and something like that. So the family has to look for the diet. That will take care of it.
Yes, sir. That's why I am telling all the peoples, not only gestational diabetes, all the peoples as a human being, we should eat what we might have eaten in the jungle. आणि आपण जंगलामध्ये राहिल्यानंतर जे काही खाल्लं असतं तेच थोडंसं शिजवून आपण सगळ्यांनीच खायचं आहे. हा माझा सांगण्याचा उद्देश आहे, जेणेकरून तुम्ही जे म्हणताय तो पॉइंट सपोर्ट होईल आणि सगळ्यांच्याच साठी महत्वाचं ठरेल. रिफाइंड कार्बोहायड्रेट्स मस्ट बी अवॉइडेड. That's all.
Yet we are come to the state of natural products, whole plant-based food. Whole plant-based food that makes a lot of difference.
Yes.
Thank you, Lalita ma'am and Sudesh sir for excellent inputs after the lecture. Thank you, ma'am, for a crisp presentation on the gestational diabetes management. We now move forward to the next academic session, which is a panel discussion by none other than Dr. Sneha Bhuyar madam on postpartum hemorrhage. Madam has been introduced, but she is, I just want to appeal for her candidature for the Vice President of the West Zone. And Madam has been an active academician all throughout for FOXY, for ICOG, as well as for AMOGS. We have seen her work in the breast committee also. So I would wholeheartedly seek all your support for her candidature. And I would like to now introduce all our panelists for today. Dr. Bharat Pawar sir, he is a consulting obstetrician and gynecologist in Akluj at Anand Hospital, Malsharas. He has done his DGO and DFC from YCM Hospital, Pune, and he has special interest in preventive obstetrics and ultrasonography and infertility. I welcome the next panelist, Dr. Kavita Kamble madam. She is a
Yes, Monica.
Samartha Hospital IVF at Karmala. She's a practicing at Ashish Higher Center since the last 15 years at Krishna Cardiac Maternity Care. She's also the president of Women's Wing IMA Karmala, the president of the Karmala Medical Guild and the colposcopist at Krishna Hospital. She has many awards to her credit. We welcome you, ma'am. Our next panelist for today. Can we have the next slide, Saiti? Yeah.
Yes, it is there.
Yeah. Dr. Sushil Sarde, sir, he is the past president of Osmanabad OBGYN Society, and he is also the owner of the Eye Hospital at Daraship. He has been practicing since last so many years with more than 1,000 patients conceived with only medical management for treatment of infertility. We welcome you, sir.
Thank you.
Dr. Anuradha Garad, madam, is an ex-president from Osmanabad OBGYN Society. She is the chairperson at the Mission Pink Health Osmanabad branch. She has been invited as a faculty for various state and national conferences. We welcome you, ma'am. Our next panelist is Dr. Sujeta Gundevar, madam. She is trained and worked with Dr. R.P. Sonawala at Navrojji Wadia Hospital, and she has been trained in advanced laparoscopy with Dr. P.G. Paul at Cochin. She is the director and partner of Sushruth Hospital, Pandharpur. We welcome you, ma'am. She has been the president of the Pandharpur OBGYN Society in 2019-20. We welcome our next panelist, Dr. Vasudha Diggaj Dapke. She is a consultant obstetrician and gynecologist at Sayadri Hospital. She has been trained in ultrasound from Mumbai and has undergone a laparoscopic training at the Family Planning Institute. She has been working as a medical officer at Civil Hospital, Darashi for the last 9 years. We welcome you, Dr. Vasudha. Over to you, ma'am.
Yes, thank you so much, Monica, making my job easy. I welcome all the panelists, and without much ado, I think we straightway go to our panel discussion. I hope my slides are visible and they are on slideshow mode. Yes, Monica, can you see the slides?
Yes.
Yeah, so very good evening. I welcome all of you once again, Dr. Bharat Pawar, Dr. Kavita Kamre, Dr. Sushil Sarde, Dr. Anuradha Garad, Dr. Sujata Gundevar, and Dr. Vasudha Varke Dapke. So, friends, we have this first case, fourth gravida, para 3, all 3 living issues. And she comes to you with 38 weeks pregnancy, unbooked, uninvestigated. She has had previously FTNDs, all 3 alive, home deliveries previously. She is, she reports at a remote CHC at around 10 a.m., but with strong labor pains, fully dilated cervix, vertex is at +2. Her vitals are stable. She's pulse rate is little high because she's in pains, and BP is normal, respiratory rate is 18 per minute. Systemic examination is normal. She delivers immediately after coming to your hospital within 10 minutes, a male child with Apgar 8 and then 10. And things are, the baby is well. But immediately after the delivery, suddenly, may I ask others to mute themselves, please? So immediately after delivery, suddenly she starts pouring like a tap. So she started bleeding very heavily. So Dr. Bharat Pawar, do we have Dr.
Yes, ma'am.
Yeah. So good evening, Dr. Bharat.
Good evening.
This patient who has come to you, she has landed up into now PPH. First I would ask you, how would you manage this patient?
Firstly, she is an unbooked patient, madam.
Mm-hmm.
So the preventive part begins
I will
from
interrupt you here. We will talk about the emergency management first, and after all the discussion, we will go to the preventive aspect. Okay. So
Now
how can you manage this as emergency?
Yes. So we have to arrest the bleed.
Mm-hmm.
For that, she should have undergone active management of 3rd stage of labor with uterotonics and manual uterotonics and control contraction with uterotonics.
Yeah, but then they have failed, but now she is bleeding. So what will you do now at this stage from here onwards?
They have given uterotonics.
Mm-hmm.
They have given, no?
Yes. What will you do, Dr. Bharat?
Yeah.
Here onwards, what will you do? Now she is your patient.
I will try some other uterotonics. What is given to her, I will see.
Mm-hmm.
If she has received pitocin, I will give her a methargine injection or prostudine or misoprostol. I will continue the
you will give
massage
everything simultaneously, or you will wait, give one uterotonics and wait for the result. She's bleeding
no,
like
I will give simultaneously, madam. Since she is at PSC level, I will prefer to give multiple uterotonics. I will continue the uterine massage. I will call somebody for the help. At the same time, IV fluids.
Mm-hmm.
I will arrange for IV fluids, crystalloids,
Mm-hmm.
and see how the patient responds.
Okay.
If uterus gets contracted, I will continue same treatment.
Okay.
I will look for any lacerations
That
or
means you're
abrasions.
suspecting only the atonic PPH, right?
Yeah.
But then suppose she has some different reason for this.
I will look for that. If she
Yeah.
has any
So that
trauma,
is what we have to say.
cervical tear or lacerations, I will simultaneously
Mhm.
arrest the bleed by suturing it.
Okay. Okay. Anybody wants to add anything?
Madam,
Dr. Kavita? Yes.
Firstly, she is bleeding profusely, so I would like to put a 2 IV lines to her. I would take out the blood for the cross match. I will like to do her basic investigation and ask a blood bank to arrange for a blood. Then simultaneously oxygen I would like to start to her. Then crystalloids, at least 2 liters has to be infused if she's pouring. If she's she is going in a shock, and then I would like to call for a help.
Whether it will be only IV fluids or it will be with uterotonics?
With uterotonics simultaneously, madam. Her first line is the oxytocin, then is a lethargy, and then if misoprostol also, I like to keep it, even if it takes 20 minutes to act, but I would like to keep one misoprostol to it, to it. And if she doesn't has any asthma and all, we can also add a prostaglandin that will have an immediate effect. It's the effect will be much faster.
Injectable prostaglandin.
Injectable prostaglandin.
Carbocross injection. Yes.
Yes, I would like to give to her.
Okay. Anything else here in uterotonic?
Yes, madam.
We can.
Yes, yes.
डॉक्टर सरडे हेअर.
Yes, yes. Please go ahead.
सगळ्यात महत्वाची गोष्ट काय आहे की प्लीज एम्प्टी द ब्लॅडर फर्स्ट.
Yes, that is what
That
we
is
are
the
trying to
basic
come
thing
to.
we are missing.
We are not missing. We are asking you to go ahead.
And we should empty the bladder first.
Perfect.
Then look for whether it is a atonic or a traumatic PPH and go
Yes.
accordingly.
That is what we stopped Dr. Bharat saying that, not only giving the uterotonics. See, first and foremost, what just now has been discussed is you have to call for help, start 2 IV lines, send the blood for grouping cross matching, send one set of blood investigations and keep a blood ready. Everything simultaneously, you will catheterize the patient, you will pack the vagina, and then you will look for, whether she has got, so empty the bladder, empty the uterus, see for any
any tissues in the
yes, so
uterus.
bone, tissue, trauma, and thrombin. These are the 4 causes basically. So that is how, it's not that you will go for one and you will wait for the other, but you will go for everything simultaneously. Because you don't know whether it is atonic, traumatic, or because of the retention of the tissue or because of the coagulation failure. So everything you will do simultaneously. Naturally, once you empty the bladder, give the uterotonics, see that the uterine tone is good. Even if it is not good, then what will you do? And she's still pouring. Then what will you do? Now, you tell me. Dr. Sushil.
Yes. I would like to start from a thing. All pregnancies are at risk of PPH. Even if
we're talking about this case.
Okay, in this case, we will go with uterotonics first.
Yeah,
what are the choices?
All types of uterotonics. You have missed carbetocin, all of you.
Yes,
so
I am coming to that. Carbetocin, pitocin, all uterotonics plus uterine massage. Uterine massage, how it is given? You put your wrist against the anterior fornix and another left hand on the posterior side of the uterus abdominally. Your main aim of massage is to compress the anterior wall with the posterior wall.
Yes.
And yes, that compression is more important than any other thing whatever for massage we are doing.
Yes, so that is manual uterine massage. Okay.
Yes.
Your right hand should be the posterior fornix and the left hand in the anterior aspect of the uterus.
Yes.
So on the abdomen. So that is how you compress it with your both hands. Okay. So
another thing,
manual uterine compression and uterine massage. Okay, go ahead.
Another thing I want to add. that is use of tranexamic acid. 1 gram tranexamic acid.
Yes.
2 grams
from-
of tranexamic acid can be
1
given.
gram.
1 gram. That is
1
1
gram.
gram.
Yes,
But
yes.
yes.
If
How do you give that?
she is unknown to us, so she may be suffering from some any clotting abnormalities.
How
So
do
we
you
can
know
cover that.
How do you know that? Now, by this time, you have given so many, uterotonics. You have emptied the uterus. You have emptied the bladder. Then now, how do you judge that it may not be the atonic or traumatic? But then that means there are no tears anywhere. The uterine tone is good. The bladder is empty. The uterus is empty. In spite of everything, if she is bleeding now, then that
Then
is
we can
coagulation failure.
tranexamic acid.
Okay.
Yes.
Okay. Then
We
what?
can now,
Madam, we will
because
like
we
to do the
have to first assess
hello.
the patient.
Hello.
Hello.
Take shift to the OT.
Hello.
Yes.
Hello.
Let me complete.
Any bedside investigations? That is what my very
Let
simple
me complete, madam. Let
You
me
do a
complete first.
BTCT for the patient.
Okay.
No.
Okay. Dr. Sushil, please complete.
Yes. Thing is that you should do all the investigations. Main investigations are PTCT, PTINR. Whether she is going into DAC or not. If
That
she
will
is going,
take time. That will take time.
okay.
That's why I'm
Then
interrupting you here.
be prepared.
Okay.
Be prepared for surgical management of that patient. If she is
Yes,
not
but if the
responding
patient
to,
is in coagulation failure, you will not be able to take her immediately for the surgical management, and that is why we should have the bedside
another
test.
thing.
Okay, bedside
One
test. I'm sure Dr. Girija, Dr. Sudesh, all of us have done this.
The
Tell me.
bedside test will see for
Yes.
the pulse rate and the BP of the patient, because we'll just we can see for the
Clinical examination, my dear. We are
Not
talking about bedside test.
Clot retraction time.
Yes.
Clot retraction time.
clot retraction time.
After you do a bleeding
and
time,
clot.
a clotting
Yes.
time, you allow the blood to clot in the bottle and you wait for some time. After around 10 minutes, the clot should retract and the serum should separate. So clot retraction time is a bedside test which can give you a fair idea about the PTINR, which will take time to come from the lab.
Perfect, perfect. So see, the previous generation has, actually done everything, and that is why we are very sure that, we don't depend on the laboratory investigations. We ourselves do all these things. So clot retraction time, as Dr. Sudesha said, after 10 minutes, and clot lysis time, even for after 40 minutes, suppose the clot becomes lysis again, that means the degradation is also going on simultaneously. What we talk about nowadays, FDP, the fibrinogen degradation products, the D-dimers, so on and so forth. So even with the simpler bedside test, you can get this idea. Only you should know all this, and you should have done this previously, or maybe you need to learn all this. So whenever you are managing this patient, you have to go step by step, practically. You don't have to go theoretically. Okay, so we are managing this case now. Put into IV fluids. So you have sent everything, given the uterotonics, empty the bladder, empty the uterus. You are giving the bimanual compression, everything. But now you find that in spite of everything, now the tone is good, but still she is bleeding. And then by your bedside test, you come to know that the bleeding time is more. So now you come to the diagnosis that it is a maybe one more thing. Still here you have two things. Either they can be something from inside, some raw area which is bleeding. So one thing is tamponade, and second is, of course, when you're sure that you have coagulation failure, then you have to go for the management for coagulation failure and the definitive surgical management. Okay, so though we have covered management in short, now let us go to the preventive aspect. So we have saved our patient. Okay, so we stop it here. We will have some more discussions as the case progresses. Now you tell me, Dr. Sujata and Dr. Anuradha, whether whether PPH, we start from the basic definition. To whom do you label that she is having postpartum hemorrhage?
Madam,
yes.
In normal vaginal delivery, blood loss more than 500 ml, and in cesarean section, blood loss more than 1000 ml. But
these definitions means blood loss estimation may not be very accurate. We cannot accurately measure the blood loss.
Yes,
So
yes.
we have to look into the hematocrit of the patient. We have to look number of blood transfusions given, how much the hemoglobin has fallen from her previous ANC record.
Do we
So
wait?
last
Do we wait
trimester,
for? Do we wait for
last
the hemoglobin
trimester
to fall?
hemoglobin is
Dr.
very
Sujata,
important.
Dr. Sujata, I would like
Yeah.
to interrupt you here. When we are managing this case of PPH, we will not wait for hemoglobin or hematocrit to fall down because we are actively managing this patient. We don't want her to go into shock. So before that, we want to even, guess at the earliest we want to diagnose. That, how do you do that? That is what I'm trying to ask you. It's not.
I want to
She
add.
has 1 minute.
Yeah.
Let me complete.
Yeah, yeah.
Suppose she has soaked one full pad, that is almost 100 ml.
Yes.
If she has soaked the bed sheet where she is lying down, then that is almost 1000 ml. One kidney tray is 500 ml.
Yes.
And if there is clot, this is a beautiful representation
There's a
of
quantification method,
blood
yes.
loss.
Yeah. So
And
one,
if there
on
is a
right
big
side,
clot,
on right side, you have this subjective, that is on the
Yes.
visual assessment. On
Brass-
left side, you have
brass
the
blood
objective.
collection tape.
Yes.
Brass collection tape, or the PPH toolkit. Actually, because the definition of PPH itself says that you have to have more than 500 ml for a vaginal delivery and 1000. The visual inspection of the loss of blood would not help in such cases. And so we as clinicians should start measuring or using this even routinely. Though it is said so is simply that and shown in the slides, I myself have less amount of using this for my own labors. So what we do is we do the two methods, the calibrated one and the other is the gravimetric method. So in the calibrated, the buttocks, the drapes are placed under the buttocks of the patient and you measure how much blood she has lost. Or if you don't have this, we measure, as madam has rightly said, we can measure the amount of pads they have soaked, and every amount we see the pre-measured weight, or we can just guess from that how much the pad is soaked and weight there. So one gram of weight will be equal to 1 ml loss of blood. So accordingly, we can see how much blood loss she has undergone, and accordingly classify her according whether it is a moderate, severe, or we need, and depending on that, a management of giving her IV fluids, crystalloids, or like later on the coagulation factors will depend. Along with this, yes, so we can use these both the methods, the calibrated one and the gravitated ones.
Okay. Anybody else wants to add anything?
Yes, madam. I want to add, madam,
Yes,
any blood loss which is causing the hemodynamic instability of a patient, I think for me it is more significant.
Yes.
A 40 kg girl who is having a 6 gram of HB will collapse in a few time. And most reliable what clinically is, I think, is a shock index. So
Yes.
that is the
Yes.
best thing what we should do earliest, and it will give us the earliest indication that she is in a moderate shock or in a severe shock. So I think it is better to go more clinical point. It is also okay to see whatever is spillover and all.
Yes, so we have to see the shock index.
Yes.
The shock
So,
index would be calculated by the heart rate.
So before you talk about shock index, I would just say this way, that even though the definition says 500 ml for vaginal, 1000 ml for cesarean section, we have to have the individualized assessment of the patient and the blood loss, right? So as Radha has very rightly said, that if an anemic woman bleeds even less than 500, she can go into shock. Right? So that is how you have to assess clinically that how much blood loss she can, definitely tolerate. So that is where comes the role of shock index. Now, Dr. Kavita, do you want to talk on this?
Yes, the shock, because there is hypovolemia, there will be less perfusions of the tissues, and so there would be tissue ischemia seen, and so the oxygen carrying capacity is also seen. Usually, the shock index is for the left, like the left ventricular output can be assessed from this, or the stroke volume can be assessed. So it is calculated as soon as you have a patient of PPH and her system, like we put on the monitor So as soon as you see the monitor, you can calculate the shock index by seeing the heart rate and divide it by the systole. If the pulse rate is 100 and her systolic pressure is 90 or less than 80 or 60, so you understand the shock index is 0.6. Normally, index of 0.9 is a good one, but a lesser index would prove that the patient is deteriorating, or the outcome of that patient would be like it would be very difficult to bring her back. So because the tissue perfusion has been affected at this stage, and so we have to be very careful when the shock index is increased or decreased.
Yes. So the message here is, it's not only the volume loss. You have to assess the clinical condition of the patient, whether she has any symptoms, which we are going to come into the next slide. And of course, you have to go for the assessment of shock index. If it is less than 0.7, then of course, she is, going to worsen. And that is what earliest you have to, go for intervention. So Dr. Sushil, now I have talked to you about that even in spite of all this, she's bleeding. So now what?
I want to summarize thing. Use brass drape in all deliveries.
Dr. Sushil, we go ahead now. We have summarized. At the end of the case, we will summarize. Yeah. What next?
Yes, ma'am. Can I talk?
Yes. What next?
Use brass drape in all deliveries. Expect PPH in each and every case. And you should perform a mock drill in all shifts with new interns or residents or nurses in the hospital. One mock drill should be performed. And develop a SWAT team. SWAT means special weapons and tactics. A team which has special weapons for prevention and management of PPH, and special tactics, what they have to do. That team you should develop. When there is patient of PPH, what to do. That team should be always ready when a patient comes to labor room.
Okay.
If Dr. Sneha, if I may add something.
Yes. Actually, we want to add so many things. Yes, Dr. Sudesh.
Yeah.
Please.
Dr. Sushil, what you have recommended is already being done in all medical colleges. Our own Foxy is doing the Manyata program. The government of Maharashtra is doing the Lakshya program. Government of India is doing the Daksha program. And you would be surprised that many times all these paramedics, including sisters and dayas, they are more efficient. They are more efficient in managing the PPH rather than the postgraduate doctors who may have not done the field work. And this is being done. And I would proudly say that this has contributed a lot to decrease the mortality in PPH. Now, all the dayas, Maushis, sisters, and I also, my hospital, have done Manyata program. A lot of people, Dr. Sujita Kundar have done, and a lot of people in Fox are doing in Manyata program. And I would urge to all the people who have not taken training of Manyata program should undergo training for Manyata program for their staff.
Sir, can I add one more sentence, ma'am?
Yes, please.
Yes.
Ma'am, I am a part of the district working group of Sholapur for Manyata. And it is really, really commendable that we have more than 60% of our private hospitals registered for Manyata, ma'am.
Wow, that is commendable.
Yes.
In fact, we should, all of us, my hospital, all of you know that it is Foxy Manyata as well as NABH accredited. But definitely what we are talking about, having the emergency, here you have the manpower which has to be ready, and the facility should be ready. They have to be trained properly. There has to be regular assessment programs or sessions. There has to be regular mock drills as well. And of course, the trolleys, the emergency trays have to be ready. So as Dr. Sudesh has said, definitely Manyata, accreditation and the training of our staff definitely helps in managing all these emergency situations. So once again, we come back to Dr. Anuradha about we want you to speak about bundle approach. How feasible is it?
Madam, bundle approach has two components. One is a technical and another is a clinical. As far as technical approach is concerned, there is a system integration, communication, transport, and all the things. Yeah. And as far as the clinical approach is concerned, there is a golden hour protocol. There is A, B, C, D, E, airway, breathing, circulation, drugs, and the exposure. Yeah. And there is a rapid initial assessment. And then after doing all this, shifting a patient to HDU. So you want me to elaborate?
Yes.
So the Bandhan approach protocol contains the initial assessment of a patient, and it contains the uterotonics of IV fluids, crystalloids, along with simultaneous uterotonics, and endpoint of a fluid of a resuscitation. Blood transfusion. So for this, madam, we have a targets of a transfusion. So we have to maintain that the pulse the pulse has to be more. It should not fall. There should not be a tachycardia. The blood pressure should not be fall less than 30. The hematocrit we have to maintain more than.
Sorry, Anuradha, I will interrupt you here. See, whenever whenever we see the patient going to shock, we always use, we always recommend that we should use these wide bore cannulas, okay? Not 40, but 16 and 18, gray
18 we are using.
color. And this has got a flow rate of here it is mentioned like 196 and 90, okay?
Yes.
So I would just take you to this, we just feel that, oh my God, she's bleeding so much, so we give aggressive fluid resuscitation. But sometimes that is detrimental because that can lead to dilution coagulation.
Dilution.
Okay. So what is hypotensive resuscitation? Can you throw some light on this?
So it consists of a restrictive crystalloid resuscitation during the early stages of a hemorrhagic shock and maintain lower than the normal systolic and a mean blood pressure, sustaining perfusion until that there is a control of a bleeding and shifting at a proper time to a blood transfusion and the blood products.
Perfect, perfect. And then comes the role of hemostatic reanimation. So how the blood and, the components are present in the body in that natural proportion, you want to transfuse the blood and blood products. So we have already discussed what is the role of hypotensive resuscitation. You want to maintain the patient's blood pressure a little lower than what is normal so that, the organ perfusion is maintained, but it does not break the preformed clots and, the bleeding doesn't start again. So the coagulation factors should not be diluted. So that is what about now we come to the therapeutic goals. So who else we have here? Dr. Bharat Pawar, do we have?
Yes, ma'am.
Yeah. Please talk about what should be the therapeutic goal for this patient's management. How should be the, the blood and blood investigation should be when you are transfusing this patient?
We will maintain HB around 8 gram.
Before that, the blood pressure, urine output, the vitals you can talk about. Yeah.
Systolic blood pressure around 90.
Correct.
Mean arterial pressure should be above 60.
Yeah. The
urine output should be minimum 1 ml per minute.
Yeah. That comes to how much? For over
30 ml to 30 ml to
30 to 40 ml.
60 ml per hour.
Per hour.
Correct. 30 ml per hour.
60 ml per hour.
Yes, Dr. Sujata, you want to talk about therapeutic goal?
Yes, we should maintain the BP, say, above 90. MAP is very important, mean arterial pressure.
Okay.
Mean arterial pressure is calculated by diastolic plus 1/3 pulse pressure. So every 15 minutes, the mean arterial pressure should be looked into. This is very important. Then we have to maintain we have to see how the urine output is. It should be 30 ml per hour, at least more than 30 ml per hour.
Yeah, minimum.
Then prothrombin time should be less than 1.5 times the normal.
Yeah.
And APTT, that is activated partial thromboplastin time, should also be less than 1.5 times the normal.
Yeah.
And fibrinogen level should be more than 2 grams.
200 to 250.
200. Yeah, 200. That is normally it should be 400 milligram, but it should be definitely about 200 to avoid the further bleeding. Okay.
And one more thing I want to add, madam, is IV fluid should not be given more than 4 liters because the patient can land up with pulmonary edema and dilutional coagulopathy. And that is the point where we have to shift the patient on PCV, Paxil volumes. And if there is a coagulation profile derangement, we have to give the patient FFP, cryoprecipitate, platelet, as required.
One more point I want to add you here, that whenever you are going, whenever the patient is in shock and you want to give aggressive fluid resuscitation, she has to be monitored with, invasive monitoring. So
CVP,
pressure.
central venous pressure. Yeah.
It has to be. Okay. So we talk about this documentation later. But how, suppose after the first response bundle, you have talked about the uterotonics and the, maybe active management of third stage of labor and the control cord traction, no uterine massage, that is the basic one. But then after this first response, now whatever you have managed this patient up to this, now she's got pallor plus, the pulse rate is 110, blood pressure is 100 millimeter of mercury, and bleeding is still profuse. How will you proceed further?
Madam, we will go for anti-shock garments. Then balloon tamponade, that will give us some time.
Before that,
we go for the preparation of the OT. We take the consent of the patient. We explain the relatives. We ask someone to explain the relatives because we would be with the patient. So make a point that explain the patient. We have done all the medical management, and even if now the bleeding is not stopped, and so we have to assess the organ, and so we might require her to take to the OT. So you take a general OT assessment has to be done. Inform the anesthetist. You have to inform the anesthetist. You have to arrange for the blood because there is blood loss. Assess the blood loss depending upon the depending upon the mean systolic pressure and all, and you assess how many points she would be required. Usually the 6:4 is required. Like you can ask for
1:1.
1:1 would be required. And
very beautifully covered, but I would still add you, I will still say some points,
Madam,
yes.
I think so there is a role of anti-shock garments.
It comes little later whenever the patient is going into shock.
And balloon tamponade.
Yes. So balloon tamponade we have covered, but if somebody can describe, but before I forget, I may just tell you that whenever you are managing these patients, what Dr. Kavita was talking about, the facility readiness, what we talked about, the manpower and everything should be
call for help.
That is one. And the duty of each person should be assigned. Otherwise, you get panic and you start throwing tantrums. This is not ready. This is not done. I told you, I need to do this. So that is the facility readiness of the infrastructure manpower. Okay, so our staff, you should know that your receptionist boy should be he should be ready to call everybody. You be on phone. One person, you be on the follow up with the blood bank. And the other staff inside, one team or maybe the assistant doctor who is talking to the relatives. So all these things have to be simultaneously. And everybody should be assigned the work. Dr. Sushil has raised his hand. If at all you have something to add, please go ahead. No?
Unmute yourself, Dr. Sushil. Unmute yourself.
Dr. Sujata, you can go ahead.
Yes, madam. Madam, I want to say that SWAT team, a team with special weapons and tactics. That includes everything, right? From doctor, sister, staff, dai up to anesthetist. That team, it should be ready whenever there is patient of high risk patient of that may develop PPH or any labor patient. You should expect PPH, and that SWAT team should be ready in every pregnant lady.
The message is, the message has to be very practical and it has to be very clear cut. Okay, so we should not follow any shortcuts or something. The message has to be very, very clear. Okay. So Dr. Bharat, once again we start from you. We have this young primary gravida with tweak gestation. She was admitted. I think we have managed that case well. With balloon tamponade, she has stopped bleeding. Okay. So now we go to this case. Young primary gravida with twin gestation. She was admitted as emergency, 35 weeks. The fetus was, The fetus was presenting, first one was with breech and second was transverse line. So naturally, she was taken for cesarean section. Twin babies were extracted. The placenta was low lying. So twins, placenta, the huge area again, spontaneously separated. A tonic PPH followed in spite of the bimanual massage and all the uterotonics possible. She landed up into this PPH. What do you feel the cause of PPH in this case, and how will you proceed with the management?
Likely to be atonic PPH due to over distension of uterus, ma'am.
That is one. We have given her all the uterotonics.
Uterotonics. Still
Quite
she is not
better.
responding.
Yes.
I will do a compression test.
Okay.
If
Perfect.
bleeding
So what is that? What
you
is
have
that?
you have to squeeze the uterus in your both hands.
Yes.
And watch
Bimanual
whether the
compression.
bleeding stops or not.
Yes.
If bleeding stops, I will proceed with compression sutures.
Okay.
If the bleeding doesn't stop,
Mm-hmm.
I will like to do stepwise devascularization and SOS obstetric hysterectomy.
Directly.
No, go for the uterine artery ligation can be tried at this time.
Yes.
Stepwise devascularization, if it doesn't respond, we will go for an obstetric hysterectomy.
If I interrupt all of you, I still got something else earlier. Okay, see, you have the uterus opened here. Twins with large placenta. The bleeding area is more. You are giving the uterotonics. Why don't you try the balloon tamponade? The uterus is open. Put in a balloon and leave the catheter outside from vaginal end. And if you instill the balloon, and if that compression stops your bleeding, then where is the need for all this? Your patient is not in shock. You have just noticed that she's bleeding. Okay, so don't jump on the management of very aggressively. Okay, simple things. If she's bleeding,
ma'am, we have less blood.
Yeah. Yes, tell me.
We have less availability of blood in the area where we practice, and to give a trial with balloon tamponade, would not that be the loss of the golden hour? Like
but how many minutes? How many minutes? We're not trying for hours together. See, you have the uterus open. You put in the balloon catheter, leave that end, you instill and you compress. By the time your blood products get ready, you have the idea that no, it has stopped now from bleeding down. And even if your patient is bleeding and your blood and blood products are getting ready, if it is not going to help, immediately then and there you can go ahead with the management. You have everything open here.
By that time, की तो tamponade वापरायचा हेच लक्षात राहत नाही.
That is why I'm here, no? That is why I'm here to tell you that don't jump. Your patient happens because by the time you are arranging for everything, no, you still have everything at your disposal. The uterus is open. You can, take some sutures from inside if at all. You know that placental bed compression sutures from inside you can take. Maybe balloon tamponade. If that doesn't work, then of course you can go for the uterine compression sutures, and simultaneously you can go with. By the time you can just go for bilateral uterine artery ligations or the yes. So stepwise devascularization you can.
Hello, madam. I want to add one thing. I want to add one basic thing.
Hello.
Hello.
Yes. Go ahead. This is Dr.
Madam. When we are doing cesarean section, the cut edges, you should close the uterus at least 80 to 90%.
Yes, definitely.
Leave 10 to 20% for checking the PPH whether there is bleeding or not. You should not leave the as it is. म्हणजे तुम्हाला युट्रस 80 ते 90% क्लोज करायचं आहे, कारण की ते ओपन एजेस पीपीएच मध्ये ऍडिशनल ब्लड लॉस करतात. आपला गोंधळ तिथंच उठून जातो.
Leave open even those 10 to 20%. Do all the panelists agree to this method?
I would like to add something. One thing.
Yes, Sudesh.
May I have some? Two things.
Yes, definitely.
One thing is we are all talking about bundle approach and everything. One thing I think which we all have missed in the discussion is I have a policy from last 15 years. We fortunately have 2 blood banks in Pandharpur to cross match 1 unit of blood for every patient who comes in labor.
That is what we are coming to. That we will come to that.
Yes. It costs only around 300 rupees. It's like insurance to the patient. And secondly, it helps the blood bank to run because it earns money only on that.
Yes.
Secondly, about you talk about when the patient is of placenta previa, you should try some sutures on the placental bed with
That is what I was
20
talking
cadget or
about.
something like that.
Yes.
Placental
Yes.
bed
Yeah,
sutures.
that
As
helps.
far as,
And thirdly, what Dr. Sushil sir has said, I agree with his point about the cut edges. But if you don't want to suture it, you can very well stop the bleeding of the cut edges with using an extra pair of green aromatage clamps, which do help. I do have 4 green aromatage clamps in my drum, and they help me a lot. So that to assess everything, till then the cut edges can be picked up by the green aromatage clamps.
What is the logic behind leaving the cut edges?
Yes.
What is the logic behind leaving the cut edges? Why don't you?
No, I'm not saying leaving it. I'm not saying
They-
leaving it. I'm not
Don't
saying leaving
leave
it. You have to do it till the time you assess the bleeding inside you.
That is.
Till then,
That
so
is
once you have an incident, get clamp it by green
achieve
aromatage.
hemostasis from the cut edges. That is what.
What I want to say, the uterus is atonic, cut edges, the sinuses are open. Close them.
Yes, of course.
Don't leave them alone. And another thing, people, they are usually doing, they are putting suction again and again inside uterus. Suction टाकू नका, suction करू नका uterus close करत असताना. तुम्ही suction टाकले की clotting factor, clotting mechanism is also another important thing that is for prevention or management of PPH. Let the patient's clotting factors act. त्या मध्ये जमा झालेल्या क्लॉटला डिस्टर्ब करू नका. प्रत्येक जण सक्शन करतो, पुन्हा एक बाईट घेतो, परत सक्शन करतो, परत एक बाईट घेतो. काही करायचं नाही. 80 to 90% युटरस क्लोज करा, सक्शन टाकू नका. क्लॉटिंग फॅक्टरला ऍक्ट होऊ द्या.
No, ma'am, we don't do the suction most of the times. Once we give it a compression and we suture it end to end and make sure that you do it in 2 layers and cover it completely with the peritoneum also.
Yeah, because regaining the contour will definitely help to achieve the tone, to attain the tone as well. And that is why we don't have to leave the uterus open for a longer period. That is also one message. So now suppose in spite of all this, your balloon tamponade, your compression suture stitch is bleeding, then of course, then there comes a role of, what she was saying. If at all you don't have that measures for going ahead with the definitive surgery, then only I think the NASG and transfer or referral, if at all you feel so, that is what that you have to save the patient, and during the transport maybe the NASG will help. But when you have the definitive surgical management there at your disposal, I don't think till you shift to OT and till you arrange for your blood and blood products, that will definitely help your management and to stabilize the patient also. So what are the general consideration while taking the patient in OT, doctor? I think we give it this to somebody else now. Kavita has talked enough. Dr. Sujata and Dr. Anuradha. Yes.
Madam, operative theatre should be appropriately ready, and we have to inform the staff, and adequate anesthetist has to be informed. Blood should be available for the transfusion. 2 IV lines we have already made. Counseling and consent has to go from the point she has started bleeding, that simultaneously we are counseling for everything, for a massive blood loss, blood transfusion, blood reactions, operation that may be required. Upon laparotomy, the bleeding at the surgical site should be minimized by the adequate sutures. In all cases, yes, uterus has to be exteriorized in all sutures. First, we would like to go for a compression sutures, like Billings sutures. Then we can add hymen sutures to that we are routinely doing. After doing Billings also, I would like to add 1-2 hymens and tie it at the top of the uterus. Ligation of both uterine arteries, also systemic devascularization that we are doing. Then definitely a senior obstetrician. We are not going to do this singly. Firstly, only at the first moment we have called for the help. And what else?
This is what about the balloon tamponade we have already discussed.
Yes,
so we'll skip that.
Discussed.
So we talked.
I want to add.
Doctor. Yes.
I want to add.
I am coming to you. We have to go ahead with this discussion. Which compression sutures in atonic PPH and which one you prefer and the reasons for this, Dr. Sushil?
Yes, I will prefer Billings suture. because it compresses, it is a figure of 8 like structure, it compresses the uterus very well. And another thing I will do simultaneously, bilateral uterine artery ligation. B-link suture, I always prefer. And main thing is that whenever we are taking the patient to the operation theater, always get consent of hysterectomy. Please get consent of obstetric hysterectomy from the patient's relatives.
Yes.
माझी स्लाइड दाखवा, माझी
So,
स्लाइड
the
दाखवा, माझे
message-
क्वेश्चन्स दाखवा, त्याच्यावरती बोलतो मी. स्लाइड वरती दुसरं
Yes.
काहीतरी येते. How easy or
Which
difficult
one
and
and when
pitfalls.
they have already asked.
Pitfalls. B-link is very easy. Bilateral uterine artery ligation is very easy. Pitfalls काय आहेत? बऱ्याच ठिकाणी काय होतं, खूप आटोनिक पीपीएच असेल, पेशंट डायनेमिक असेल, B-link सुचर काम करत नाहीत, मग अशा ठिकाणी आपल्याला डायरेक्टली ऑब्स्टेट्रिक हिस्टेक्टॉमी साठी जावं लागतं. महत्वाची गोष्ट एक परत सांगतोय मी, ऑब्स्टेट्रिक हिस्टेक्टॉमीची कन्सेंट घेतली गेलीच पाहिजेत. आणि ऑब्स्टेट्रिक हिस्टेक्टॉमी करताना एक महत्वाची गोष्ट ही आहे, क्लॅम्प कट राईट साइड, क्लॅम्प कट लेफ्ट साइड विदिन 2 minutes. आणि देन आरामात तुम्ही निवांत लायगेट करत बसू शकता निवांत. पण क्लॅम्प कट first clamp, second clamp uterine artery, first clamp.
To remove the bleeding uterus out fast. That is the message. Because
yes.
you want to remove
So
the uterus
clamp
out fast.
cut, and then ligate. Clamp cut, 4 clamp झाले आपले दोन्ही बाजूला, आणि मग शांततेत त्यांना व्यवस्थित टाय करायचं. पण क्लॅम्प कट विदिन 30 seconds दोन्ही बाजूचे 4 क्लॅम्प लावून आपण युटरस कट करू शकतो.
Okay, so I can see 3 participants. So I would ask Dr. Sujata first. Yes.
Madam, I just
Yes, Dr.
wanted to
Sujata.
add, when we are taking B-link sutures, the assistant has to compress the uterus so that the knot is tight, because otherwise if it starts feeling again, then slip off of the braces can occur and the suture will go fake. So that is an important thing.
You should allow the uterus to fill and you just compress it and then you tie it.
Then tie the
sutures.
sutures.
Dr. Sudesh, you want to say something?
Yes. I'm not very well or very happy with B-link. What I usually prefer is Cho stitch, which is like a mattress suture. Go anterior, posterior, square knot at 2 or 3 places, which places are bleeding, because that compresses that site where it is. B-link has sometimes a pitfall of the braces being falling up, as ma'am said. And if you have taken the wrong suture for the B-link instead of catgut, if you have taken vehicle or something like that, places are on the record where the suture has cut through the uterus into 3 slices like a cake.
Yes.
So I personally prefer to go for Cho. I don't have personal experience with B-link. I am happy with Cho. I go with Cho. B-link, people are using it. It is a good suture. But with my hands, I personally prefer to go for Cho.
We can add both of them together, sir. Sometimes you could have totally bandhun takta sir.
Yes, the PPH is such a dreaded complication. It's not only the multiple types of suture, but sometimes you may combine the multiple surgeries together.
We can do that together.
Yeah. So, Dr. Anuradha, which one has, what are the practice points you want to say for this? Okay.
Madam, I prefer B-link. And many times to B-link, I add Hyman's 1 or 2 sutures. And then I tie it at the top of the fundus. And the position is also important, madam. When we are doing it, it's better to give a semi-lithotomy position and to see simultaneously bleeding. Even though we are doing it a supine position, but when we are planning these surgical procedures, it's better to keep a patient in a semi-lithotomy position. And I prefer Chos, I don't prefer because multiple sites, I think it bleeds a lot. I prefer B-link because all the sutures which we are taking are on the lower segment, and it's less likely to bleed from the site from where we are taking. So I am happy with B-link. And I have done it many times. The only thing what I have seen that when I opened the patient for the second time, that imprints of the B-link I have seen, ma'am, for the repeat section.
Yes,
Means that
definitely.
is that
All of
strong,
us are
imprint that uterus will bear it for its lifetime. The village
lifetime.
taken.
We'll have the marks also. So
Yes.
it's not only the compression sutures or different types of compression sutures. As I said, you may have to combine even the different types of surgical management. So along with compression sutures, the bilateral uterine artery ligation as well. So any comment you want to make on this uterine artery
Madam,
ligation?
I would
Yes.
like to add, we have to even ligate the ovarian artery because there is
That we have discussed
anastomosis
earlier. Bilateral uterine artery and bilateral
and
ovarian
ovarian
artery that we
artery
have said
ligation
stepwise
should be done.
revascularization.
Yeah,
Yes.
because there is anastomosis between them. So even if the uterine artery is ligated, the patient keeps on bleeding. So ovarian artery ligation is also very important. And we can think of modified B-Lynch suture, which is
Any
also known
similar,
as
any comment or any precaution for that uterine artery ligation? Because you always, you are in a hurry to, see that skeleton. Some people do that skeleton. That is wrong. In fact, you have to take a deep bite through the uterus, very close to the uterus.
ureter.
And
We
then
have to be very careful about the ureter.
ureter, correct. And what about the ovarian artery? How do you do that? You just pick up the fallopian tube and through the transparent area, just go from anterior to posterior and just tie a knot. You don't have to pierce the structures in between. See that no vessels you are piercing. So it is very, very simple. Okay. So stepwise. Sujata, do you want to add anything? This was your question. Anything else?
No.
You want to add on the internal iliac? Yes.
Yeah, internal iliac ligation, I will be speaking now. So now if everything has failed, since if it is a case of cesarean section, abdomen is open, the best approach now will be the internal iliac ligation. As we all know, we are ligating the anterior division of internal iliac artery. And the anterior division starts almost 3.5 to 5 centimeters below the starting of the internal iliac artery. It is the anterior division which supplies the whole of the pelvic viscera. Pelvic viscera. So if we tie the anterior division, we can reduce the blood flow by almost 40 to 80%, depending upon each case. We use a right angle blunt forceps and we put it from medial to lateral with slow movement without injuring the structures below the internal iliac artery. The most important structure there is ureter. We have an external iliac vein there, and by the side we have the external iliac artery. So once we introduce the right angle forceps and it has come from medial to lateral side, we feed in a stout ligature and we withdraw in the same plane where we went without injuring any structure. And before ligating, once again confirm that no external iliac vein, no ureter, or no external iliac artery is in the ligature.
Okay.
And then you can ligate it by 3 or 4 knots, and that's it.
Yeah, I think majority will agree to me that ligating bilateral uterine artery itself, almost to the tune of 90% we are successful. But yes, in some patients, where you don't find any cause and the patient is bleeding like a tap, you have to go for internal iliac artery. And if that also doesn't work, you have to go for the hysterectomy. Anybody already, Dr. Sushil has covered the option. Yes,
Madam,
please.
We have just forgotten about the endovascular coagulation. There is a role of endovascular coagulation.
Yes.
Before going for hysterectomy, because if the patient is desirous of
interventional radiology, yes, definitely.
And because if the patient is desiring pregnancy further, we have to think of that.
Yeah. Yes,
Hello,
definitely it is there. Uterine artery embolization, this is the slide, okay? Okay, so that is what I'm talking about, that bilateral uterine artery ligation or bilateral uterine artery embolization, what I mean to say, the success rate is greater than 90% with lower complication, provided you have the, facilities for interventional radiologists available. It can be attempted if you really have that facilities, and where definitely the patient's childbearing or, she's desirous of further childbearing. This is, of course, a very, very effective measure, and the success rate is almost 90%. Yes.
Yeah.
Yes, doctors, I could hear some voice here. Dr. Sushil,
Hello.
is it?
Yes, I want 4 points to add.
Okay.
All
Go ahead.
pregnancies are at risk of PPH even if no predisposing factors are present. Averting maternal death is based on having a prepared mind of a doctor, prepared team, and a full range of possible therapies. Number 3, a SWAT team, that is special weapon and टॅक्टिक्स असणारी टीम तुमच्याकडे हवी आहे. आणि नंबर 4 खूप महत्वाचा पॉइंट आहे, आपला ओटी मध्ये पीपीएच थांबला, आपण पेशंट वॉर्डामध्ये शिफ्ट करतोय, वॉर्डामध्ये किंवा आयसीयू मध्ये जिथे कुठे शिफ्ट करणार आहेत, त्याच्या अगोदर पेशंटच्या नातेवाईकांकडून ना ही कल्पना दिली गेली पाहिजे की पहिल्या 24 तासामध्ये परत नंतर पेशंटला ब्लिडिंग होऊ शकते, सी मे गेट पीपीएच अगेन, आणि त्यानंतर आपल्याला ओटी मध्ये घेऊन हिस्टेक्टॉमी करायची गरज पडू शकते पहिल्या 24 तासामध्ये. या गोष्टीची कन्सेंट घेणं अत्यावश्यक आहे. नाहीतर एकदा पेशंट बाहेर आला आणि नंतर पेशंटला सेकंड पीपीएच बसला आणि आपण ओटीत घ्यायचं म्हणलं तर कुठलेच नातेवाईक तयार होणार नाही. त्यामुळं पेशंट बाहेर काढल्यानंतर पहिले 24 तासामध्ये अगेन हिस्टेक्टॉमीची गरज पडू शकते. या गोष्टीची कल्पना आणि कन्सेंट नातेवाईकाकडून घेतली पाहिजे. थँक्यू.
Yes, definitely. When we talk about the informed written consent, what we have been telling to the patient and relatives, that definitely this patient has landed up into postpartum hemorrhage, and right from the minimal treatment, medical management extensive, to blood transfusion, to obstetric hysterectomy, to even the maternal mortality, everything has to be explained, and informed written consent has to be taken from the relatives. That is one. And for all the procedures of postpartum hemorrhage, we have to be cautious and tell the relatives that just because we have done this treatment, that is not the end of this treatment, and still we have at least 24 hours to be, talked about the safety of this procedure. So that is what is to be conveyed. So very good point, Sushil. And this is what the answer to the question, can you predict and how to prevent? So anybody can talk about this if at all. I think I now want, who else is remaining? Dr. Bharat Pawar?
Yes, ma'am.
Yeah, please talk about this. How do you predict and prevent the PPH? For this case, you forget that you was unregistered and uninvestigated. But otherwise, every patient coming to your antenatal OPD, how do you predict and prevent PPH?
Risk stratification should be done for every patient. Anemia should be corrected. High-risk patient should have blood ready during labor or during cesarean section.
Yeah, before that, I would say that you have to identify the high-risk patient. You have to identify that, yes, this patient is high-risk. As Dr. Sushil has said, or all of us or as obstetrician agree unanimously that PPH is unpredictable. Okay. Without any reason, she can bleed, that is one. But if the patient has high-risk factors, definitely that has to be notified and that has to be tagged or labeled her as high-risk patient. Okay. Then during the procedure, during labor,
active management of third stage of labor, I prefer to give carbitocin instead of pitocin or methargine, with which I have a good response. And fourth stage of labor should be managed very well. You have to observe the patient for 1 hour post-delivery. Maximum PPH can be picked up at that point and treated very well within the golden hour, where we get a good response for medical management.
Yes, yes. But the monitoring, I would say, for first 24 hours.
Yeah.
Yes. Okay. And once how do you diagnose? You should have a high index of suspicion that we have talked about. And then, of course, the visual estimation and the objective evaluation of blood loss and the clinical condition of the patient. And once you assess, then you go for the proper management, what we have done. So this is how I think we have covered almost everything. Dr. Sujata, thank you for that, uterine artery embolization, which actually is there in the slide, but we have forgotten actually to discuss that. And I would just end by, these three messages. So any message you want to give from your side? Already, I think all of you
Yes,
have
madam.
given
Madam,
messages.
one message.
Hello, madam.
Yes.
One
Yes,
message
yes. So I would ask all of you to only one single liner message now.
Yeah.
Okay.
All the since internal iliac ligation is a life-saving measure, all the residents should be taught that procedure.
Okay. We can have one line message. That is what I said. Yeah.
I will like to ask a question. Anybody has an experience with suction cannula or Panikar's cannula for management of atonic PPH?
In fact, I was about to take up this after you finish, and I would ask also Sudesh too. But then before that, any other point to be discussed?
Dr. Anuradha, you are muted. Dr. Anuradha, you are muted.
Madam, in this area of a repeat cesarean section, and when we are talking of a PPH, I think we should be very, very particular about placenta accreta spectrum, locating the placenta and making it very sure that it is not accreta, increta, and percreta, and be ready for that.
Okay. Any other message you all want to give?
Madam, history of PPH in previous pregnancy, previous delivery.
Yes.
That is very important because this
Mhm.
time there is lot many chances that she will have PPH.
Yes. So there was a point of regarding the suction. Okay. So in fact, I don't find by any way the suction. Two things I want to tell you as a UG. All of us have learned that tonsil and uterus. These are the two organs where in fact the blood, if it is clotted, then that will bleed more. Correct, Sudesh? So that's a very reason. Do not allow any blood to clot or remain inside the uterus. That's a basic thing. So doing suction, if the uterine cavity is getting filled, is correct. And you should, in fact, keep the cavity, compressed or toned and then empty. Everything should be done. What somebody was asking is Dr. Bharat, I think.
Yes.
We do have the suction cannula. One is Samarkram's cannula and the other is Paniker's cannula, Dr. Vasudev Paniker's cannula. And what the basic principles of management of PPH is, they create a negative pressure inside the uterine cavity. They want to suck out everything to the tune of, that the uterine cavity collapses on the suction cannula. And,
it acts like compression sutures.
Yes, so this acts like a compression suture, and it is one of the most effective measures for management of postpartum hemorrhage. Purposefully, I have skipped this because we still have one or two cases with me, but this I have not included. This has been accepted very well, not only all over India, but all over the world, I think. Sudesh, you have any comment to be made for this?
Sorry, I have no personal experience with Paniker cannula, and we had to meet a person who has used it. Maybe you have used it, you may have the first experience, but I am yet to meet a person who has a first-hand experience with Paniker cannula.
Yeah, I would just share with all of you that, see, my experience is for 32 years in the field of obstetrics. Sudesh knows me. I was his senior in Bijay Medical College. Even I am practicing at a small district place called Yavatmal, though I belong to Pune. But these things, you learn by experience. So when something is better than nothing, so you have to keep trying new things. But as I said that, for PPH or maybe for any emergency, I would say, you have to use multiple gadgets or measures or drugs or procedures. Whatever works the best, you don't know what has worked exactly, but till your patient becomes, stable and she stops or comes out of the complication, we just say that everything collectively has helped. And that is how we just say it's not me who have managed this patient, it's the team who has managed the patient. And the message from this discussion is that for such kind of patient, multidisciplinary team approach is recommended. And that's a very reason, even though all of us don't agree, the Supreme Court says that whenever you are practicing a high risk obstetrics, all of you must have a obstetric SDU and ICU, which is next to impossible. But I'm sure, call for help, call your colleagues, expert and experienced, maybe senior or junior, but absolutely no shame or no shy. Don't feel shy calling all your colleagues. I think that is the only message. Keep a high index of suspicion, predict, try to prevent, that means avoid all the exaggerating factors or precipitating factors, and manage when you have to face this as emergency with a multidisciplinary team. So with this, I think we conclude this panel discussion, and I would like to thank all the president and secretaries of all the 3 societies I have already welcomed and thanked you in the inauguration. I would like to thank all my expert panelists, all of you. I have welcomed you, and I'm thanking you. And I just take this opportunity to humbly seek your best wishes and support for my candidature as Vice President Foxy for the upcoming elections. I hope I deserve, and I request for your votes.
Yes,
Thank you so
you
much.
deserve much
Sure,
more,
sure.
much more than that. Best wishes from Akluj OBGYN Society, ma'am. We wish and support you all the time. And thank you for blessing us and coming to our place also. Thank you so much, ma'am.
Thank you, dear. Thank you so much. Over to you, Monica.
Yes. Thank you, ma'am, for the opportunity to coordinate this session. Thank you, Akluj, Pandharpur, and Osmanabad societies. Lalita ma'am, Sudesh sir, and Shetty sir have been very, very helpful in suggesting all the faculties for this webinar. Thank you so much, all the presidents and secretaries of the associating societies. Thank you, Sahiti, for the technical assistance. I would also like to thank Dr. Sunita Tandulwalkar madam, Kiran Kurtkoti sir, Ajay Mane sir, and Pardeshi sir for joining and gracing the occasion. Our chairpersons for today also have done an excellent job, ma'am, because they were there all the time and they have given their inputs, as well as there was a discussion post the lectures also. Girija ma'am and Sushila ma'am have done their best and given the best academic inputs. The panel discussion was the icing on the cake, ma'am. I would also like to thank all the panelists for giving their excellent academic inputs and a lot of take-home messages for all the delegates. Thank you so much, sir. Thank you, Sudesh sir, for being there till the end.
Yes. Thank you so much. I would like to again thank
And
all the
Lalita ma'am
president
also.
and secretary. And thank you, Monica and Dr. Madan, for wonderful coordination and all the help. Thank you so much.
Madam.
Thank you.
Thank you, ma'am.
Thank you. Bye-bye. Bye.
Bye-bye. Good night.